خلاص. مريم اوكي. واضح. الو. اوكي اوكي alright.
دكتورة مريم السلام عليكم، ازي حضرتك؟
اهلا وعليكم السلام يا دكتور.
سامعاني كده كويس؟
انا سامعه كويس.
طب تمام، احنا هنبدأ بحضرتك ان شاء الله.
تمام
بس ان شاء الله هنبدأ يعني بعد 5 دقايق ان شاء الله.
ماشي تمام يا دكتور. تمام
بالتوفيق ان شاء الله.
شكرا جزيلا.
دكتور محمد مساء الخير. مع حضرتك مصطفى جلال من سي بي.
مين؟
مع حضرتك مصطفى جلال من سي بي. استاذن حضرتك بس تعلي الصوت لان صوت حضرتك بعيد جدا.
بعيد جدا؟
طيب صوتي انا واضح يا استاذ مصطفى؟
صوت حضرتك واضح جدا يا دكتوره مريم. صوت حضرتك.
انت سامعه صوتي بعيد يا مريم؟
انا حاساه مقبول، يعني هو بعيد بس يعني انا سامعه.
يا محمد فعلا الصوت واطي فعليه كده.
مش عارف اعليه ازاي. طب قول لي اعليه ازاي كده.
ممكن حضرتك تستعمل المايك اللي حضرتك كنت استعملته امبارح لانه الصوت امبارح كان واضح عن كده.
انا كنت داخل من اللابتوب.
طيب.
تمام. طب هحاول ادخل من اللابتوب برضو تاني. طيب اوكي.
دكتورة مريم ازيك؟
اهلا وسهلا بحضرتك.
حضرتك كده.
دكتور شريف وصل اهو كمان. الحمد لله على السلامه يا دكتور.
ايوه
شريف.
الله يسلمك يا محمد.
يا محمد احنا جماعة البحرين ما حدش بعت لهم انفيتيشن لسه. انا بعت لهم النهارده ما كانش يعرفوا بالميتنج. ومش احنا عندنا داتا بيز لكل المؤتمرات اللي فاتت المفروض تي او بي بتبعت
بالظبط.
طب والنبي اكد عليهم يبعتوا. مصطفى انت سامعني؟
سامع حضرتك كويس يا دكتور. ايوه.
طب والنبي مصطفى في عندنا داتا بيز من الاربع مؤتمرات اللي فاتت فناس كتير ما وصلهاش. راجع الداتا بيز دي وابعت للكل.
تمام جدا يا دكتور هوصل لهم. تمام اوكي. احنا عامة بنبعت ايميل شوت وبنبعت اس ام اس فانا هوصل لهم برضو على المعلومات دي. اكد عليهم المعلومات دي.
هم كانوا حاضرين من سنتين. المجموعة كان جاية من البحرين تقريبا 5 أو 6 بس ما حدش. أول ما قلت لهم يعني لسه هيدخلوا النهارده.
تمام جدا.
محمد ممكن نبتدي؟
اتفضل يا بيت، اتفضل نبدأ إن شاء الله.
Good afternoon, everybody. Thank you for attending the second day in the Scoliosis Week. Today's session will be on AIS, addressing idiopathic scoliosis. And let's start our day by a resume on the physical therapy for scoliosis, and to be delivered by Dr. Mariam Ibrahim from Asyut University. She's a certified orthopedic physiotherapist and board certified. So, Mariam, can you please start giving your talk? Thank you very much.
Yes. Hi and welcome everyone to guidelines of specific exercise prescription for the AIS. Next, please. We will go just quick on the lecture objectives. We want to expose the clinician to accept the guidelines and research for the conservative treatment of AIS. We want to prioritize the level of care for AIS patient upon the risk of progression and other variables. Understand the goals of conservative treatment according to or based on the individual needs. Next, please. What is the conservative management? The conservative management is the education of family and patient on scoliosis and activity of daily living and how it affects their ADL, observation and monitoring the curve, progression and the changes. And the most important thing is scoliosis specific exercise, and that's the main focus in our lecture today. Bracing part or full time, and evaluation and treatment of other comorbidities. Next. The main indication for conservative treatment is the patient who present with AIS as adult or adolescent, and other indications may include congenital scoliosis or deformities in the sagittal plane. Some cases may be treated with physiotherapy, but with limitation, like syndromic and neuromuscular scoliosis, post-operative scoliosis, post-operative scoliosis fusion, adult onset degenerative scoliosis, and finally infantile and juvenile onset. Next, please. Treatment guidelines according to SOSART, and SOSART is one of the leading and international scoliosis societies that we are going to mention after. The guidelines, this is the summary for the guidelines. We will go back to this slide one more time, but we want to present the abbreviation of the summary. OPS will stand for the observation every 4, 6, 8, 12, and 36 months. And PSE is the physiotherapeutic specific exercise for scoliosis, nighttime rigid bracing, part-time rigid bracing, full-time rigid bracing, and SU for surgery. Next, please. This chart concludes the summary of the guidelines, where we can see the specific exercise. We do it for the patient who has COPS angle under 35 degrees. Next, please. And this is the continuum of the chart. Next, please. What are the precautions to physiotherapy? Precaution to physiotherapy is spondylolisthesis, osteoporosis, juvenile hypermobility syndrome, osteogenesis imperfecta, and major psychiatric problems. Physical therapy is contraindicated if we have reactive scoliosis or during the active phase of inflammatory disease. Next, please. Treatment guidelines, the younger and more skeletally immature the patient, the higher the curve at the diagnosis, the higher the risk of progression. And we will need this information later. The higher risk of progression, the more intense conservative treatment plan should be. We want to avoid the under-treatment, and we also want to avoid the over-treatment. Next, please. These are the two leading and international societies that we conclude the guidelines from them. The Scoliosis Research Society and the Society on Scoliosis Orthopedic and Rehabilitation Treatment, the SOSART and SRS. And on the next, slide, next please, we will find, hello? We will find that table concluding the differences and comparison between both guidelines. In SRS guidelines, they tend to have from 15 to 20 degrees. In COPS angle, they tend to have the idea of wait and see. They just use the observation. While SOSAR, they use more of treat and see. They consider early bracing and early specific exercise in select cases. From 25 to 45 degrees, SRS guidelines will recommend brace, while SOSART will recommend the specific exercise and brace and education. From 45 to 50, they both recommend surgery, but the thing is, SOSART guidelines include that this patient may do physiotherapy until the surgery decision is done. Next, please. These are some challenging questions that we all meet with a scoliosis patient. Is observation really a treatment? The answer is, it is part of the treatment. We want to observe the patient to understand what is the curve better and how the curve is progressing. So in some cases, yes, we just do observation. We don't intervene with anything with the patient. Is bracing alone too passive? For me, it depends. Sometimes we need some active interventions, some active exercises to prevent muscle weakness that may happen with only bracing. Can earlier intervention help prevent the surgery? This question, the answer is not clear, because we still lack a lot of literature review that support either yes or no. So we don't have answer to that question. Parents, they are too much of wait and see. And the patient, they have the lack of empowerment to help themselves. Physical therapy doctors, in reality, they have inadequately educated and equipped in scoliosis treatment, and this is the reality in all over the world. Ortho surgeons, they looking for alternatives to the surgery. Next, please. What are the goals of conservative treatment? And this is the most important slide in my presentation. We want to stress that we do physical therapy to stop the curve progression. Sometimes, possibly, we even reduce it, but it's not always reduce it. We just want to stop the curve progression. We want to prevent or treat the respiratory dysfunction, and we want to prevent the spinal pain syndrome, or treat the patient if they're complaining of back pain. And we want to improve the posture of the patient. Next, please. To have a scoliosis, you need to have two components, the posture component and the structure component. In physiotherapy, we only work on the posture component. We do not do anything on the structural component. We just work on that component, the posture component. And why it is important to work on the posture component? Next, please. Because there are muscle imbalance. We want to consider the various degree of rigidity, and we need to have the patients and give the time for the tissue to adapt the auto elongation that we are going to do in physiotherapy. Next, please. The vicious cycle, this theory will help us to understand why the physiotherapy sometimes break the progression of the curve. If we have asymmetrical, if we have spinal curvature that is abnormal spinal curvature, this will lead to asymmetrical loading, and the asymmetrical loading will lead to asymmetrical growth. And if we have asymmetrical growth, we have wedge vertebrae. If we have wedge vertebrae, we have more of scoliosis, of more of deformity. So if we intervene with rehabilitation to break the cycle, this cycle, in with the neurophysiological vicious cycle, with the muscle length tension relationship, we will have this cycle broken, and we will decrease the progression or stop and prevent the progression. Next, please. This will show how the neurophysiological vicious cycle affected by physiotherapy via the intervening with the muscle length tension relationship and the afferent receptors that is going to the subcortical center. Next, please. So here are some examples of few goal setting that we might do, just fitting into how to set a goal when you refer the patient to physiotherapy. Case 1, patient with severe curvature at high risk of progression, and at high risk of progression, and the Cobb's angle are 40 degrees and Risser are 1. This patient is for surgery, but you might refer them to physiotherapy just to stabilize the scoliosis through the skeletal maturity in order to prevent the progression of the curve to be 50 degrees. Next, please. Case 2 is a patient with moderate to low risk of progression, and he is complaining of low back pain. So that patient, we will do physiotherapy for him to stabilize the scoliosis as well, but to help him to demonstrate proper sitting and bending mechanics without any low back pain. Next, please. The third case is a patient with moderate curve and lower risk of progression, but he or she is complaining from shoulder and scapular pain with reaching. Maybe she has unlevel shoulder, and maybe she has prominent scapula, and maybe it's not either of them, but she still complaining of shoulder scapular pain. We want to tailor exercises for each part, for the right side and left side, and for the thoracic spine, in order to gain scapular stability, in order to reduce the pain while she is doing her reaching activities. Next, please. The last case is mild curve in young patients with unknown risk of progression. We don't know the risk of progression, so we just want to monitor this patient every 3 to 6 months and educate them about the posture and mechanics to avoid progression of the curve. And when I say we monitor or observe, I don't mean that we send the patient for X-ray every time they come. We just monitor them and do the X-ray only when we communicate with the surgeon, and we both accept that the patient needs to do X-ray. Next, please. So what is the definition of specific exercise? PSSE stands for Physical Therapy Scoliosis Specific Exercise. The definition is it is autocorrection in 3 dimensions, and it is restoration of the sagittal plane, and it is patient education and spinal stabilization. It's not an alternative to bracing or surgery if either of them indicated. And physical therapist who is experienced in specific exercise should have fundamental understanding of the spine biomechanics and the curve better. Next, please. These are the main differences between the traditional physiotherapy and the physiotherapy specific exercise for the scoliosis. In traditional physical therapy, we often use side bending if we want to stretch the concavity, if we have scoliosis in in aged patient or in geriatrics or in patient who is not AIS. So we can use the side bending, but we can't do side bending on scoliosis with AIS without controlling the rotation aspect of the deformity, because side bending to the convexity side may worsen the convexity of the other curve in case of double curve scoliosis. Next, please. Core strengthening. In traditional PT, we use pelvic tilt and abdominal set and crunches in order to activate the core or strengthen the abdominal muscle. While with scoliosis, we have to understand that flexion will worsen the torsion of the spine. We can't do that with the scoliotic patient because that will promote more curvature. So we train the core stabilization in neutral spine, and we control the deformity in 3 dimensions. Next, please. Traditional, the same things. Traditional PT will use in stretching the flexion, but we don't use flexion to stretch the paraspinal muscles in scoliosis. Again, this will worsen the case. Next, please. And spinal mobility. Some people they use manipulation or mobilization to address the positional fold, but I myself do not recommend mobilization and spinal mobility with scoliosis patient, but some people they use it, and it is in the literature. Next, please. Using heel lift to balance the pelvis. If we have uneven pelvis in traditional patient, sometimes we use heel lift even if the patient does not have leg length discrepancy. But in scoliosis patient, we do not do that because we want to balance the pelvis. We use only the heel lift to balance the uneven pelvis if we only have true leg length discrepancy. Otherwise, we don't use heel lift with scoliosis patients. Next, please. The last thing is the accommodation and correcting the posture. Traditional patient, if they have fixed and scoliosis and they complain, for example, that they are not feeling comfortable while they are sitting, we sometimes advise them to put pillow in between on the concave side to fill the gap. But we never do that with the scoliosis patient, because if we tell them that such an advice, they will accommodate to that. The curve will get worse just because we are accommodating the curve. We want to work with the posture component. So we don't want the patient to accommodate. We want the patient to correct the posture. Next, please. So what are the principles of correction? The principle of correction is auto-elongation, asymmetrical sagittal straightening, frontal plane corrections, corrective breathing for the intercostal and diaphragmatic muscles, muscle activation for more spinal stability. Next, please. This is an example of one exercise that we let the patient do with verbal and tactile stimulation to help them to know where they should move, which part to which side. Next, please. And we want to have clearly in mind that we have altered muscle orientation and scoliosis for the paraspinal muscles, the latissimus, quadratus lumborum, obliquus, and psoas muscle. So we work on all of them that affected. Next, please. So in summary, how we coordinate the care. If we have skeletally immature patients, scoliotic patient, we want to ask what is the risk of progression. And we want to work as a multidisciplinary team to deliver the optimal care for the patient. And if the patient is skeletally mature, we want to ask what are the patient goals and what are the spine, if the patient complains, if he has spinal pain or not, and how his posture. We want to do posture education. Next, please. This is the only slide I want I just wanted to give an idea that we have post-operative rehabilitation protocol, and we have another webinar that we are going to discuss in details the post-operative protocol. Phase 1 we do active rest period, and this is the maximum protection phase until 12 weeks. Phase 3 is the minimal protection phase, and phase 4 is the dynamic phase and getting back to normal, and it may be up to 1 year. Next, please. So my take-home messages are that although some evidence has shown that the superiority of some specific exercise in comparison to traditional physiotherapy, it's still too soon to make a general statement about their applicability. We want to work as a multidisciplinary team to deliver the best care. We want to have a good communication between the surgeon and the physiotherapist to deliver the best care for the patient. Next, please. This take-home message is for physiotherapists. The scoliosis is a complex 3D structural and geometric deformity of torsion. We cannot control that deformity with just uniplanar force, with just side bending or just rotation. We have muscle imbalance that are weak in both shortened and lengthened position. So we want to work bilaterally to activate the muscles in both sides to address the bilateral weakness. Thank you.
Thank you very much, Dr. Mariam. This is a new approach to the physiotherapy and scoliosis. I'm sure there will be a lot of questions, but we'll keep it to the end of the session. Okay. And it gives me great honor and pleasure to introduce the next speaker, Dr. Joseph Al-Khalil from Lebanon. Dr. Al-Khalil is not only one of the best surgeons in the area, but as you will hear, he will be one of the best lecturers. You would like to listen to him. So Dr. Khalil will present on correction techniques in adolescent idiopathic scoliosis. Joseph, can you start, please?
Yeah, thank you. Good evening, everyone. Thank you, Dr. Yusri. So what we start with today is just basics. You're faced with a scoliosis. So, and you know all these techniques, and you have like 12 techniques on how to put the spine back in its place. But the idea is which ones to use. And back actually 2 years ago, a study published by Lenovo showed that there's a significant variability between surgeons, even experienced surgeons, on which maneuver to use, which instrumentation to use when you're planning a surgery for AIS. So how I think of it is whenever I'm like learning how to do something is one, I learn the what. What does that mean? So what can I do? So what are the techniques? So I'll go through them in a bit. You got, for example, the derotation, the coplanar, and all these techniques. And then I need to know how I have to do them. Then I need to know when to do them. So which part of the surgery I need to do this maneuver. And then where to use them. Should I use them in the concave, in the convex, in the thoracic, and the lumbar? And most importantly, so the what, the how, the when, and the where is knowledge. Why is understanding. So once I understand why I'm doing this technique and what does this technique offer me, then I can know to which patient, so the who. Which patient I need to apply this maneuver rather than that maneuver, or a combination of maneuvers. And the first thing you need to know is your instruments, what you're dealing with. So that's rods and screws mainly now. So you get your titanium rod, your cobalt chrome rods on your stainless steel rods, and that's with increasing stiffness. And what you get in stiffness, you have to kind of let go as far as risks. That means the stainless steel is very good. It resists deformation when you're reducing, but sometimes the stainless steel is more powerful than the interface between the screw and bone. So you have a higher risk of pulling out. The titanium is more malleable. You can bend it as you want, but that's also can be a negative because instead of actually pulling the spine to the rod, you're actually deforming the rod to the spine. And the cobalt chrome is kind of in between. And just so you know, in metallurgy, in a solid cylinder, increasing the diameter just by a bit, you actually increase exponentially the stiffness of the curve. So you need to know the stiffness of the curve, the spinal cord tolerance, and you're not aiming to get a perfect X-ray. You're aiming to get a perfect X-ray with minimal to no complication. So sometimes over-reducing a spine can give you neurological complications, screw bone interface, or even worse, screw pull-out or migration. And you need to memorize the importance of bones. This applies more in adults, but also in patients with neurological complication and bedridden patients. So how I usually do it is I use the cobalt chrome as the reduction rod. I'm using a single rod because it deforms less. And then I use my titanium rod as a holding rod. Once I get the reduction that I want, because the rod will lose a bit of its stiffness and it deforms a bit. So I put the titanium rod as a holding rod to prevent further loss of correction. And just be careful, because I've seen residents bending and overbending and then underbending and correction. Every time you bend a rod, even a bit, especially the circular rods, you create a small divot, and that divot kind of fragilizes the rod. And if you get a delayed union, and that zone will become too fragile and the high risk of rod breakage. And something as simple as what to use in cutting the rod. Should I use a handheld? Should I use a tabletop? And actually, biomechanically, it has been studied that a tabletop is far better because it gives you a more powerful cut without actually deforming the edge of the rod. Second step is knowing your screws. So you get your monoaxial screws, your uniplanar screws, and polyaxial screws. And the screw rod interface is actually what's getting you your reduction. So it's the tulip, the top part of the screw. The rod will hook on that and will pull and that before the rotation, and will pull the tulip and the screw and the vertebra towards you. So in monoaxial screws, that would be the perfect, because the tulip doesn't move. So you don't lose that translation or that torque in the tulip screw interface. However, they are the most difficult to align. And with their powerful in reduction, you have the high risk of pulling out. The uniplanar, so the screw on the right, has only a freedom of movement in the sagittal plane. So it's a lot easier for the tulip actually to capture the rod, and so you can put your set screw. And it has, because it doesn't move in the lateral plane, it has a lot of derotational power. Polyaxials are the easiest to use as far as rod capture and alignment, but of the three, they have the least vertebral derotation when they are mobile. However, when you fix a connector to the screw and you make the screw tulip interface rigid, then it becomes like a monoaxial screw. So which of the two is more powerful? As I said, uniplanar have better coronal, okay? However, the uni and polyaxial have more rotational axial improvement. So, and that's been studied by multiple publishers, mainly Kuklu and al. So if you do a translation, the uniplanar and polyaxials can translate the spine, but the uniplanar are better at rotating the spine. And now we know that spinal derotation, and we've heard it yesterday from KV, that it is very important to rotate the vertebra and with it the chest cage, especially when you're dealing with upper shoulder balance issues. So pedicle screws, you can use extended pedicle screws and it makes rod capture easier. You can use uniplanar apical concavity screws because that would give you most rotation in the most rotated vertebra. Polyaxials at the upper and lower foundation because you don't need the rotational component. You can use hooks for the upper instrumented vertebra. And as we saw yesterday also with KV with the claw construct, it has a lot of maneuverability in order to reduce the shoulders. And it is easier for a soft landing. And we'll see in a bit how that helps prevent the PJK. And especially now, if you're planning to do a DVR, you need, of course, the deformity sets. Polyester bands are a modification or a new technique of the old Lucas system, where actually you get bands, and these bands can hook behind TPs under laminas, and they have somewhat of a good rotational, but mainly it's a translational power with a minimal risk of either cutting out or breaking, as did the cerclage wires with the Lucas system. So how do we prepare the spine for the maneuvers that you want to do? Of course, you all know the releases, posterior, anterior. I'm not going to go into all that. And you know all the osteotomies that we do and all the typical releases that we can perform anteriorly or posteriorly. So these are in red most of the reduction techniques that we use. We go from distraction to translation, single rod derotation or rotation, cantilever, inside to bending, compression distraction, dual rod derotation, and finally vertebral derotation. And we're going to go through each one separately. Distraction is the first one that was used by Harrington. So you put a single rod on the concavity, you hook it up at the top and the bottom, and you pull the spine. It is the easiest technique to use, but it gives you the least information, and you don't kind of understand the 3D issue of the spine because you're only trying to correct the coronal. And we all are dealing now with the flat backs of the post-Harrington instrumentation. So the first technique to use is the two-rod translation. What does that mean, two-rod? So what you do is, so that's your concave side. So you put your rod how you want it to be, okay? So that's your rod, and you fix it at the top and the bottom. You fix your rod, and then you try to bring the vertebra to the rod. So you translate them. And that could be by different ways. It can be by an extended tab screw. It can be with a hook system and a reducer system, even with a polyester band. Here, you're just translating to the rod, okay? You don't do a lot of derotation. And the problem is if you're using a soft rod, like a titanium rod, and if the spine is stiff, you can have a pullout, or you can have a flattening of the rod. Finally, once you have all these screws captured, you can do a rotation. So you can rotate towards the convexity, and that will actually help a bit in order to get a bit of rotational component in your reduction. So this is the basic technique. So translation to rod and final single rod derotation on the concavity. This is the basic, let's say you're doing a Lenke 1 technique. The single rod rotation, the idea comes from Cottrell Dubussy. And the issue is, especially if you're having a dual, a double major or curve or a dual curve, is that you bend the rod to the shape of the curve. And then you put the rod capturing all the screws that you've put. And then you rotate the single rod. And the idea is you transform the concavity into kyphosis, and you transform the convexity into lordosis. Ideally, this should be good. But the problem is there's a lot of load sharing because the screws in the entire system actually share the load, but there's no axial rotational correction. You correct the rod, sorry, the spine. However, your correction doesn't always coexist or equal to the sagittal alignment that you need to have. And we saw with the Rusuli types that sometimes the concavity doesn't correlate with the amount of thoracic kyphosis that you need, and vice versa with the lumbar lordosis. So this system is good in the dual curve, but it's not perfect. You can modify this in doing dual rod. If it's too difficult to do a single rod rotating the entire spine, you can put two rods. So you can put one rod at the top, one at the bottom, and then once you rotate them both, you can connect them with the rod-to-rod connector. I used to use this technique before DVR and the deformity sets were more available. When I was doing a single rod derotation, in order to help me capture the screws and help me minimize the stress on my concavity screw. So the way I was doing it, I used to put a small rod on the apical convex screws. And I used to put the rod down and lock it up. And I used to ask the assistant to grab it with a very powerful rod holder. And then while with his left hand pushing down on the rib, with the right hand actually is pushing down on the rod. And this will somewhat deliver the spine to the rod on the other side. It will give some rotational correction. It's like doing a small in block on the concavity side. And my convex concavity screw are big, are powerful, and I'm more at ease using them to powerfully reduce the apex rather than on the apical screws. The cantilever technique is, we use it a lot in kyphotic deformities, where you actually hook up the top part or the low part, and then you push down, and by pushing down, you correct the sagittal deformity. You can use that in the dual curves, where you put the rod on the convexity and then you push it down in order to capture the lower curve. But as far as coronal correction, it is far more difficult than when you're using it in sagittal, because it allows you for a segmental capture. So you capture one screw after the other screw after the other screw going down, and that will share the load rather than putting it on one or two screws. And finally, the fine tuning. So the fine tuning is compression distraction and in situ bending. In situ bending, you can do it as a whole. So when you put your entire rod, and you can use it as a major reduction technique when you bend the entire spine. But one, you're just correcting in one plane. Two, there's a high risk of catastrophic failures. And in soft rods like titanium, actually it's the rod that will bend and it won't correct the spine. So I don't recommend the in situ bending for big deformities. I can recommend it for minor corrections between 1 or 2 levels. And the compression distraction is the fine tuning, is usually used at the bottom and at the top in order to help get the lower certain vertebra more horizontal. And also you can use it to compress or distract at the UIV in order to help with the shoulder balance. And finally, the derotation. So the direct vertebral derotation is the most logical way of reducing the scoliosis, because being an axial rotational problem, derotating the spine will technically give you the best reduction, will give you the most powerful thoracic correction, and it will help correct the initial problem. You can use that by 2 means. Either you can get 3 by 3, so you get 3 vertebra and you get multiple unblocks, or you get segmentals. That means once you capture the rods and your screws, you can 1 vertebra at a time grab reduced a few degrees. And I let the spine relax. I let the spinal cord adapt at the new position. And I let the screws kind of, I would know which screw I'm losing, which screw is not holding as good as I wanted to. So it is very powerful, but also it has a very high risk. So in the other techniques, the risks mainly are for screw pullout. That means the screw will go out on the same trajectory that you pulled in. So you get either pedicle fracture or screw pulling out, losing the screw. Here, because you're rotating, you have a high risk either of screw kicking into the canal, or the screw breaking the lateral wall into either the psoas or the aorta, especially at the apex where the aorta is more posterolateral. So it is very powerful, but the risks are also major. So when you're getting osteopenic bones and small dysplastic pedicles, you need to be careful. As I said, DVR is one of the best for correcting hump deformities without the need for thoracoplasty. One last technique is differential rod contouring. So you get your concave rod and you overbend it. The issue is to combat the rod flattening that I talked about, because instead of actually on the concavity, bringing the spine to the rod, actually you lose a bit of the rod bend. So when you overbend the rod, even if it loses a bit of that bend, you still get the thoracic kyphosis that you planned. So that's why I use the cobalt chrome, as I mentioned before, as my reducing concavity rod. And then on the other side, on the convex side, I use an underbend. So the reason why is because if you underbend it and you're pushing down, so you push on the convexity and you pull on the concavity, and technically that's what we want to have. So this is a very nice kind of picture describing what we need to do. And if you notice, so when the rod is high, so the purple rod is high in the middle image, and if you grab it and pull the screw up, and on the right side, the green is the convexity. So the green is low and the purple is high. And if you capture both, the green is pushing down, the purple is pulling up. So technically, you're having somewhat of a derotational component. So differential rod contouring is very simple and actually can help you restore rotation. And this is published by Seki a few years ago, and they found that so they did different maneuvers, and intra-op, they did a low-dose CT scans, and they measured the AVR, the apical vertebral rotation, after each technique. And they found that single rod rotation gives you around 2 degrees at best. If you do differential rod contouring, you add 4 degrees. So you see how powerful that technique is. As I mentioned, it does actually do help with the derotation. And if you do a DVR, segmental DVR, you add another 5 degrees at each level. So if you do these 3 techniques, you get around 10 degrees at every level, which is very powerful reduction maneuvers. A new technique that is becoming more and more used is the convex first rod. So we were taught that on the concavity, use the concave rod first. Otherwise, you end up having a problem either with lordosis or not enough kyphosis in the spine. So we were taught that convex first in the lumbar to give lordosis, concave first in the thoracic to get kyphosis, except when you are getting hyperkyphotic, the rare form of EIS. However, multiple studies started by Velosphere and mainly by UCAR, where they started to use the convex rod first. One, why? Because it's less risky for the spinal cord. It is easier, it is safer, the screws are bigger, the rod is away from the pedicle. So you're getting a safer maneuver technique. And they found that not really, you don't get a less kyphosis than concavity. And this is the technique published by the original article by UCAR. And if you notice that they only put the concave screws, and I'll mention that why now. And they put the old concave on the convex screws, and they put the rod and they rotate. And then once they rotate the convex rod, the concave screws become easier because you're not bending down to putting the screws, especially in the apical vertebrae. So actually, when they reduce the rod, they reduce the spine, the putting concave screws becomes easier. So they put the concave screws and they put the holding concave rod. And multiple publications, recent 2017 and 2012, actually showed that both using the convex first and correcting it even in dual rods and dual curves is as good as concave first. That's another article by Tirai mentioning the convex first. Valisperi mentioned the vertebral coplanar. We're actually using a lot of extension dual rods. And when you put the rod inside the connectors and you're pushing it down, you're actually doing a translation and rotation at the same time. Finally, reduction techniques preventing PJK. So at the top, always try to maintain the capsule. If you try to maintain the soft tissue, there's many techniques. You can put percutaneous screws at the top while maintaining the soft tissue coverage at the most proximal UIV. You can put hooks for soft landing. Don't forget to overbend the rod at the cranial edge. Usually, I don't like to push the rod to capture the UIV. I like my rod to be seated in the tulip when I'm putting the set screw. So how do I usually do it? So this is a usual single curve Linky one. So I still use the concave first, but now more and more I'm using the convex first. I put a full pedicles on the concave side. I use uniaxial extended tab in the 3 periapicals. And on the convex side, I use my anchors, my top and bottom, and 2 apical screws in order to use either a DVR if I have, or a short rod and a rod gripper. And I use a single rod derotation with differential rod contouring. So I use a cobalt chrome overbent on the concavity. And then I use a progressive reduction. So I use multiple reduction clamps, and I use the extended tab on the axial in order to reduce. And I distribute it up and down in order to get the reduction. So that gives me mainly the translation and a bit of the rotation, using it as a DRC and a single rod derotation. Then I underbend the second rod, the titanium rod, on the convexity, and I do a minimal segmental derotation on the vertebrae, especially the apical ones where I have both screws. I don't do derotation. We have to get both screws in a single DVR. And then I do a compression distraction at the bottom and top in order to correct any shoulder imbalance or horizontalization of the bottom level. If I do a convex first, the same principle, but the other way. So there's no one maneuver that is perfect. You do need to know them all, because sometimes one maneuver doesn't work. You have to switch to another one. You need to know what is positive and negative in each of these techniques, and know whatever the patient, the curve, or the pedicle allows you to do this technique. And you can mix and match whatever suits the curve and the patient. Thank you.
Joseph, thank you very much. Very illustrative presentation. I have one burning question. You're using a cobalt chrome rod on a tulip made of titanium. So there are 2 different metals. Does this increase the risk of the nuts becoming loose or loosening of the screw itself in the body?
Yeah, so of now been like 10 years I've been using them, and I asked actually the people at both companies I'm using if it's okay to use cobalt chrome on a titanium interface. And I haven't seen, even when I came in and revised instrumentation forever, even after a year or 2 years, I haven't seen any increased friction or kind of metallurgic reaction at the site. So as far as I know, there's no issues with using a cobalt chrome inside a titanium tool.
Right, thank you. Are you ready with your next presentation?
Yes, yes.
So this will be another very interesting presentation on when treating severe rigid scoliosis. What osteotomy do you like? Is it a Smith? Is it a pedicle subtraction or a posterior VCR?
So I think Dr. Bilal will talk about the VCR itself. So I won't go into details about the PVCR, but I'll mention what can we hope to get when we're dealing with these kind of patients. So this is a patient who has a neglected AIS. She came to me with around 90-degree curve, and she was in agony. And the reason why usually these patients come to us
Joseph,
so late.
please share your screen. Share your screen again, please.
Okay, sorry. So the reason why these patients usually come to us late, one is financial issue. 2 is there's a few centers in either Lebanon or anywhere else that deals with these complex cases. So this patient came to me at age 18. She knew that they had scoliosis, but due to financial problems, they came in very late. And the issue is how to get someone from here with a 90-degree curve, a stiff 90-degree curve, to this in a safe way. That's the idea. So when do we get a high magnitude curve? Usually it gets with a aggressive style pattern curve. and mainly in developing countries where you get a very long waiting period, 5 years, and in even some advanced countries where you get like mainly the NHS or economical system that allows a very delayed public system. However, most articles, once you decide that you need surgery, the accepted delay is 6 months, and even some researchers say 3 months. But we know that sometimes these patients, once you decide for surgery, they can leave and disappear for a year, even more. However, when I was reading the literature on what is a severe rigid AIS, there's a big difference. Each article kind of gets their own number. Lanky says it's a 70 and 30%. I've seen articles saying, no, it's a 60. Others say it's a 90 or 100. The percentage of correction mentioned, it can be less than 25 to less than 40 or 30. So around 80 degrees and 30% correction, less than 30% correction is the kind of the average of all of what I've read. And how do we get a maximal safe correction? So you get mainly these 3 techniques. One is traction. And that traction can be done externally via a halo or any other system, or internally. It's like the growing rods, but you use it a temporary distraction internally until you do your final fusion. And releases. We all had to do releases, whether anteriorly, posteriorly, or a posterior extrapleural extracavitary spinal release. And the releases should be both bony, ligamentous, and discal. That means you have to release the ALL and the PLL. You have to remove the annulus. You have to pretty much empty the disc space in order to correct, to able to collapse the spine and distract it on the other side. And for bony releases, you get the osteotomies. And we all know Schwab's grading that goes from 1 to 6. And the 2 workhorses of AIS are 1 and 2. We rarely get to the PSO. The majority of what we're doing in most moderate to early severe or flexible high grades are the Ponte Smith-Pearson's type facetectomies and all that. Once you get to the PSOs or to the high grade osteotomies, that's when you get more morbidity and more complication rates. So the VCR, so the types 5 and 6, whether it's a single level VCR, vertebral column resection, or multi levels, can either be done anteriorly and posteriorly, or a single PVCR. So the PVCR was kind of favored by surgeons as Suk and Bradford and Balenki. But remember, these are high magnitude surgeons. And we'll see in a bit by publication by Lenke and co, and we'll see the names of these surgeons. And they do a lot of VCRs, adults and pediatrics, and we'll mention the amount of complications they have. And Bacaludis in 2011 published which patients should you use a thoracic PSO in pediatric deformities. And they kind of gave a rough kind of estimate on what osteotomy to use for which patient. And that depends on curve flexibility. And the curve flexibility can be at the initial presentation. So when the patient comes, you do your benders and you check how much percentage of correction you get, or you can get after you do your release traction system. So just before you're doing the final surgery. If you get more than 40% correction, then you can be good with a grade 1, grade 2 Schwab, so a simple Smith-Pearson or facetectomy. If it's between 20 and 40%, then you go into a PSO. And usually PSOs are used for sagittal correction. But if you're doing an asymmetrical PSO or any other modification, so you can do a decancellation or neck shell or a colon osteotomy published by the Italians. So you can do multiple types, but it's the same principle. And if you have a very stiff curve, so you correct less than 20%, then you get a VCR, whether an AP or a posterior only VCR. The halo traction system. So the halo traction is you do that at the edges, so between the skull, and you can either use a counterforce in the pelvis, in the femur, or the tibia. The 3 upper techniques had a lot of complications, but Stanagra actually published the gravity halo traction, and they found it to be very efficient. It's a soft way of distracting. You get progressive correction, you can get immediate neurological assessment because the patient is awake. So every time you add a few kilos, you assess how that affected the patient. And the aim of the halotraction is to minimize the correction needed intra-op, and that would give less strain on your implants and on the spinal cord. The idea is okay, but that would put the patient more weeks in hospital, more cost and all that, and more delay of the surgery. Well, in 2020, in the spinal deformity, Davis published that whether it's inpatient or outpatient, you get actually the same result as far as correction. And the number of weeks for an outpatient was actually less. So usually 4 weeks instead of 6 for an inpatient. So how and when do we usually use the traction gravity stage? So usually it can be done either as a pre-op. So even before any surgery, you can put your patient on halogravity traction, or you can use it as an in-between stage. You do your release, you do your traction, and then you do your surgery. Or you can even do an intra-op. So as a single stage, or during the surgery, you do your releases, you track the patient, and you put your rod. So the stage 1 is usually release, soft tissue release, bony release, osteotomies, usually 1 and 2 are grade 1 and 2, and you put all your screws. So that usually is stage 1. Stage 2, you do your HGT, and that it could be between 2 and 4 weeks. And usually it's a progressive, you increase every day a bit the weight, but you should not go beyond half the body weight of the child. So should you go more than 4 or less than 2? Actually, Daniel published a few years ago that 60% of your correction happens in the first 2 weeks. And the remaining correction, about 30%, happen in the next 2 weeks. So in the first 4 weeks, you're getting the majority of correction and the most of it in the first 2 weeks. However, the complications happen more in the second 2 weeks and much more after the first month. So multiple studies saying 2 or 3 or 4 months of traction actually have a high risk of complication, especially pin tract infection. And once you get with the HGT, then it's final surgery. That's when you go back to what we discussed with Palakloudis. If you need to do more osteotomies or you're happy with your reduction percentage, then you can put your final correction. For example, this is a patient starting with 140 degrees, and you do your initial release, you do your posterior extrapleural releases. So this is an apical thoracic release of the discs. And still, with 4 weeks of traction, you get around, starting with 105 degrees after the first surgery. But with the halotraction, you manage to get down to 35. And actually, our good friend, Dr. Wael Kubtan and Dr. Maligi published in 2012 their series on comparing patients with halogravity traction versus none. And they found that with their triple stage, so anterior release, halogravity traction, and they only did it for 2 weeks in instrumentation, they had a better correction, a shorter surgery time, and no major complication. And most of these patients were using Lukey systems, so wire and with the anchoring, with the anchors on pedicle screws, and they managed to get these kind of corrections. One of the biggest, if not the biggest, actually series published by Bawashi of the Focus Spine Research Group in 2018. So it was the largest series of halogravity traction, 96 patients. So the Focus score is a very good score, and we're trying to apply it more and more when we're doing heavy patients. So the Focus score is a score from 0 to 100, taking multiple criteria from the patient, the procedure, and the curve. And the higher you go with the score, the higher the risk of complication. So like yesterday, Dr. Shafter was talking about the frailty index. So this is kind of the Focus score. That means it helps you know after which benchmark I should say, no, this is too much, too risky, I should say no. And actually the score is 74. So Bawashi said, after 74, the high complication rate prevents me from operating. And they found that if you're using HGT, your score actually drops 18. And you get around 30% correction, coronal and sagittal. But most importantly, the rate of planned 3-column osteotomies dropped from 91% to 39%. So these are patients at the beginning said, okay, this probably needs either a PSO or a VCR or that. It went from 90% to 40%. So more than half of the patients, with the help of HGT, didn't use the VCR and all the complications. And this is a meta-analysis published actually last month, where by the Chinese, they found 42 studies studying the HGT. And in all these 42 studies, only 372 patients. So there's not a lot of literature out there. And as kind of collective finding, they found that the reduction in the coronal, around 30 degrees, 28, and in thoracic kyphosis, 26 degrees. However, there's a major reduction in neural complication and the use of 3-column osteotomies like we saw in the Boashi study. And there's a reduction in operative blood loss. So between gravity traction, PSO, and VCR, blood loss goes from 1.5 liters to an average of 2, and then to 2.7 liters. And this is in a children. So the volume of blood is much higher than what you think of as an adult. So, and the meta-analysis found that HGT works best if you use it as a stage 2. So after you do your release, whatever release that would be. So the improvements, patients improved in height, in pulmonary function, most importantly, because actually it expands the chest cage, in nutritional status. And we know that these patients with a high curve, they come with a low BMI and a low abdomen and an abnormal lymphocyte count, and they improve their tolerance for surgery. However, they found around 22% complication rate, which are minor to moderate complications. Usually the neural complications, the cranial nerve and nystagmus usually are reversible once you release the traction. Most common are the pin tract infection, which increases much higher rate after 4 weeks. For example, this is the case that I did. And the case, as you see, went with 90 degrees. And this I used because I don't have readily available halo. So what I used is similar to this. This is not the patient. This is from a Zhang in 2020. Similar to this with a transfemoral traction, but I use simple tongs. So the tongs are very available. Most hospitals have them, unlike the halo. And actually you can see just by doing the releases, the minor osteotomies and the releases, you get a major correction. So more than 30%. And the final correction, because this patient is very osteopenic, didn't move much. So I didn't put a lot of stress on my construct and relied mainly on the traction. And these have been found that in our intraoperative halofemoral traction with severe curves published by Hamazoglu in Istanbul in 2008, found that the way they did it, so they took under GA traction films pre-op, and if they saw that the curve went down below 60 degrees, just use the pedicle screws, you don't need more than that, because they think that a traction film under GA will give you the amount of correction that you get intra-op from a simple traction. But if the curve doesn't go down below 60, then you do intra-op halofemoral traction. And those patients were 15 in their series. And they found that just by traction, similar to my patient, you get a 50% improvement in the major thoracic curve. So it went from 120 to 60 and 33% in the lumbar curve from 60 to 40. And there's an improvement also in the sagittal curve. So from 102 kyphosis to 48 degree of kyphosis. So similar to what we saw in my patient, that simply by doing simple releases, posterior releases, and halo traction with femoral traction, you get around 50% of your correction. And another Turkish using this technique, not only for very severe, but for moderate to severe. So the 1790 found that just by the traction actually improved from a 50% to 87%. So technically 87% is all we aim for in correction of AIS. So you just need to put your screws in. The other technique is a stage TID. That means you do your correction. Instead of putting the distractor outside the body, you're putting the screws inside. You put screws up, screws down, simple, same as a groping rods. You put your rod and you distract. Okay, and some kind of recommend doing every 2 weeks, but we know very well the rule of decreasing return. that after the second reduction, the distraction, you won't practically get anything. You get mainly what you get from the first one. That's a small tip. The anchors that you use for the distraction, don't use them as the final UIV or LIV, because there's always loosening of the screws inside the pedicle. For example, this is an example by De Silva. You get your original 110, you do your releases, you put your concave rod, you distract, you get to around 75 degrees, and then you come 2 weeks later and you do your final corrections and you put your final rods with a result of 50 degrees, which is more than acceptable starting with 110. And this is another study using multiple patients, anterior release and internal distraction. And you can see that they went from 130 to 60 to 59 with the final correction. And then at 32 with the final surgery. But when is VCR needed? So this is a patient, 120 degrees, not bigger than the ones we saw before. And this is the stage 1. So you do your releases, you get to minor distraction, you get to minor 108. But even with the HCT of 4 weeks, you only go down to 104. Again, we go back to Balaklodi's classification. You don't get much less than 20%, then you need a VCR. And with the VCR, it's very powerful. We all know that. And practically you can do whatever you want with the spine with cost. So what is the cost? And if you want to see the names of these surgeons, that's Lawrence Lanke, Paul Sponsoler, Schaffelberger, Sukin Shah. So these are the world-class surgeons, and they chose 7 world-class surgeons for 7 years, and they found only 147 VCR for severe pelvic deformity, pediatric deformity. So that 3 cases per surgeon per year. So I don't see anyone else doing that many in a year to get their learning curve to help. And the correction, we all know, it corrects around 50% coronal, 50% sagittal, operative time averaging 550 minutes. Blood loss is around 1.6 liters, which is more than half the percentage of blood volume. And you get to sometimes 8 liters blood loss in multi-level VCRs. 60% complications, 60%. You get 30% neuromonitoring changes. However, no complete and irreversible paralysis were found in the series. So great results, but great risk. And a study published by I think the Finnish in Finland found that in 27 patients they followed with their health-related quality of life in patients done with the VCR, they found that although you're getting 64% of correction, you're getting 44% of complications. And this is one of the studies comparing the title of this presentation. But I didn't find any study in AIS. I found it in congenital scoliosis. So they take head-to-head release, distraction, PSO versus VCR. And they found 24 patients with the VCR, 17 with the triple stage release TID and pedicle screws. And they found similar corrective results. However, you get a higher complication rate for VCR. And this is a kind of review. So more than 90 degrees, less than 30% correction, you're getting a severe rigid, and you get these types. If it's a gradual long curve, then we suggest a triple stage. So you do your release, halo gravity, instrumentation. If you don't get enough correction, you can do an asymmetrical PSO. If you have a sharp angular deformity, then yeah, you can do a grade 4, grade 5 Schwab grade, so kind of like a VCR. So traction, you can use it externally, internally, stage, or single or intra-op. Extensive release is essential, and we saw that to get the best out of your gravity fraction, you need to get a good release. Osteotomies 1 and 2 are the workhorse. You really need to do more than those. PSO is excellent in severe kyphoscoliosis. VCR is an excellent tool for reduction. However, it's highly morbid, and it should only be done specialized hands and centers. Thank you.
Thank you very
Joseph,
much.
thank you very much again for a great presentation. And I would have the honor to present the next speaker, Dr. Khalid Faraj from Libya, worked in Europe and France, and then he went to Qatar, and then he's now a freelance in Dubai. Khalid will present on.
Good evening, everybody. I am.
معلش يا دكتور يسري، هو بس دكتور خالد في العمليات is in the operating theater and he sends the presentation recorded.
Okay.
And we're planning to hear it later in this webinar, as he may join after 7:30. Anyway, as you like, we can go for it. It is ready now. Okay.
Okay. Is it ready now?
Yes, it is ready.
Okay.
And it is a recorded one.
Everybody.
Okay.
First of all, I would like to thank Professor Yusra Al-Hawari, Professor Muhammad Khattab, and Professor Sharif Al-Gimri, as well as their organization and scientific committee for all of their hard works and dedications during this 5th annual Scoliosis Week under the major circumstances of the COVID-19 to keep the course running well. Many thanks for you inviting me to be a speaker in your international conference. You signed to me to talk about the selection fusions of the AIS, which is following last night webinars that I attended, and all of the speakers last night did the excellent job and very good comprehensive presentations and covered most of the AIS topic. My talk will be just limited to some subjects or objects related with the selection fusion of the AIS. The history of the revolution of scoliosis will be just presented lightly. You talked last night about all of the kind of the scoliosis, management, treatments, all of the investigation needed, diagnosis, as well as the structure. The history, my subjects will be go through this topic, including the introduction, definition, benefits, parameters, criteria, including the radiological criteria, complications, adding on phenomena, revisions, extensions, as well as touch classifications with the literature review and conclusion at the end. As we know that the history and the revolution of the scoliosis in general, after the 1950s, when discovered, the undefoldments of the Harrington rods and hocks, followed by a significant revolutions after the pedicle screw used with a different sizes, as well as thickness and the mobility associated with a different kind of the scoliosis cages, which is a control and prevent any kind of a residual rotations or transition. After that, with the neuromonitors, including the update technology in the radiology, with the GBS OR, make a significant change for the treatment of the AIS. Selection fusion is a critical debate concept in the literature and focusing on minimizing fused vertebra segments of the major structured curve for the correction of the AIS and maximizing the non-fusing mobile vertebra and segments for a minor non-structured curve, which will be corrected spontaneously. This topic is a crucial part of the surgical treatment of the AIS, particularly in the young patient who deal with a stress of the fusion mass, proximal and distal, to the fusion area for many years. Selection fusion is a concept that has default over the controversies, and it is defined in the isolated thoracic fusions with the linky 1C, 2C, some of the 3C, some of the 4C curves, as well as the isolated thoracolumbar curve is in linky 5C and some linky 6C. Some surgeons strongly believe that more rigid and straight spine provides predictably excellent outcome. Others recommended a mobile and less straight spine. The topic is a crucial part for the surgical treatment, as I mentioned before, for the AS, particularly in the young patients, athletic, active, who will deal with a stress of fusion mass, proximal and distal junction over many years. SFAIS is described as minimizing the fused vertebrae segments of the major structure curve for the correction of the AIS, and maximizing the non-fusing mobile vertebrae segments of the minor non-structural compensatory curve to correct it spontaneously. The benefits from the surgical treatment of the AIS is a halt curve progressions and correct the deformity, maintain a balanced spines in the coronal and sagittal planes, preserve many mobile spine segments as possible, prevent surgical complications such as suctional kyphosis, proximal and distal, adding on phenomena, extension and revision surgery. Only the thoracic curve is fused, leaving the flexible lumbar curve to correct spontaneously, with the advantage of the reduced length of the instrumentations, a duration of the surgery, as well as a stay in the hospital and blood loss, etc., with a good spine mobility. As we know that and presented in your conference, that the types of the curve in general, including the proximal thoracic, main thoracic, thoracolumbar, lumbar, combined, double, triple, or S-shaped curve, as well as the curve if it is a true or false double measure patterns. Types of the SFAIS, it will be selective fusions in the thoracic curve and selective fusion in thoracolumbar lumbar curve. General treatment of the AIS depends on the magnitude of the curve and the risk of the curve progression. Curve with a magnitude less than 20% in general do not require any treatment and are followed by a regular follow-up 4 to 6 months until the skeletal maturity. Curve with the magnitude between 20 to 40 degrees are treated with a brace and regular follow-up until the skeletal maturity. Curve larger than 40 degrees are surgical candidates. Correction of the main structure's curve and spontaneous correction of the compensatory curve. Most common presentation of the scoliosis, as we know, it is a right-sided thoracic curve with a rib humps and higher right shoulder. Few patients develop additional lump or curve, which is may rigid or flexible. These are known as a double curve. Surgery of the AIS is now mostly done by the posterior approaches. Previously, it was when it is rigid and it is the angle is more than 120 degrees, it will be treated in 2 stages, starting with the anterior stage for release, followed within 1 week by a posterior stabilization. With the deformance and the revolution of the pedicle screws, as well as the neuromonitor with the images technique. So the 2 stages done in 1, and it's mainly through the posterior instrumentation. Neuromonitor provides the constant monitoring of the neurology during the surgery and helps identify the strain on the spinal cord, reducing any incident of the post-operative neurological deficit. This is a linking classification system, as we know, 6 types with a as well as the structure criteria, including the lumbar spine modifiers, which was presented very well yesterday, and everyone know about it. Most of the time, the lumbar curve is a compensatory present only to maintain the coronal balance in the setting of the fixed thoracic curve structure. Linky 1C to C3C for C curve, so that the compensatory curve will undergo spontaneous corrections following selective thoracic fusion, which means that flexible compensatory curve are able to correct spontaneously after fusion of the main thoracic structure curve. One of the key features for the Linky classification system is the ability for the system to guide the surgeon in treatment. Each Linky curve type indicates which part of the spine should undergo selective fusion. Linky type 1C curve, only the thoracic curve should be undergo fusions by classification, but yet many surgeons prefer to fuse both curves. The difficulty now lies in determining which patient should be undergo selective fusion and which vertebrae should be included in the fusion. The parameters divided in two areas. One is patient parameters: age, sex, weight, heights, patient lifestyle, activity, sport, expectation of the correction, maturity, including menarche, razor, tri-radiate cartilage. For the curve parameters, including the locations, the type, magnitude, associated deformity, abnormality, like shoulder levels, humps, pelvic levels, amount of the curve need be corrected. Selective thoracic fusion Linky 1C, 3C, 4C is to allow for as many mobile vertebral segments as possible. Patients will still achieve a spontaneous corrections of the minor curve. Linky and Bridwell criteria, including relative apical vertebrae translation, AVT, apical vertebral rotation, AVR, cup angles, flexibility of the two curves, sagittal plane assessments for the thoracolumbar junctions. Thoracic apical, the radiological criteria with the Linky as well include thoracic apical vertebral translations, AVT, which is defined as the distance between the C7 plumb lines and the center of the apical body of the apical curve. The thoracolumbar lumbar AVT is the distance between the center of the apical body of the thoracolumbar lumbar curve and the center sacral vertebral line. The ratio of the thoracic AVT and the thoracolumbar lumbar AVT is larger than 1.5, indicates more translated 20% or more thoracic curve that may treat it with the selective thoracic fusion only. Radiographic rotations may be replaced by the scoliometer measurements. The third factor is the magnitude of the curve in the cup measurements. The thoracic cup measurements should be 20% more than the thoracolumbar lumbar cup range. This is a kind of a criteria which is showing that it is a Linky 1C, 2C, 3C, 4C with a clinical feature of lifestyles and activity level, thoracic rotations more than the number, and the coronal plane ratio should be AVT thoracic over the AVT thoracolumbar more than 1.5, possible AVT criteria only. And if it AVR thoracic over the AVR thoracolumbar more than 1.2, and the thoracic cup angles and thoracolumbar cup angles more than 1.2, better if there are 2 or 3 criteria met together. Sagittal plane criteria: thoracolumbar T10 to L2 kyphosis is than 10 degrees. Sagittal disc angles below lowermost instrumented vertebrae lordosis. Tri-radiate cartilage closed completely. TL and LC side bender is than 25 possible of the TL thoracolumbar lumbar side bending more than 25 degrees. And the thoracolumbar lumbar curve is than 60 degrees if more criteria met. CSL touches thoracic LAV or below. For the thoracolumbar lumbar selective fusions with the linky 5Cs and C6 candidate with the same lifestyle and lumbar rotations prominence more than the thoracic prominence, soft tissue flexibility, thumb abduct test. So the coronal plane ratio, it will be AVR thoracolumbar over the AVR thoracic, it will be more than 1.25. AVT thoracolumbar lumbar over the AVT thoracic is more than 1.5. So it is possible AVT criteria only. And for the second one, it will be better if it is 2 or 2 criteria met together. Sagittal plane criteria, thoracolumbar T10 to L1 to L2, kyphosis less than 10 degrees. If the UIV between T10s and the L2. Closed of the tri-radiate cartilage and thoracic side benders less than 25 degrees, possible if more than 25 degrees in more if more criteria met. Thoracic curve less than 40 degrees, possible if the more than 40 degrees if the T10 to L2 more than 20, if the UIV more than 10 or equal, sorry, at the level or more T10s. There are some factors to decide the selective thoracic effusion for young, active, athletic patients, and family must know there is some kind of the underlying complication that can be happen, including the lumbar curve progression, adding on phenomena, proximal and distal junction problems, further extension and revision surgery, physical examinations with the add, which was presented yesterday in full details, including the add and forward bending test. Very important. Thoracic rotational prominence should be larger than the lumbar prominence, can be measured with the scoliometers. Flexibility in the thumb abduct test is important, and if the patient is very flexible, selective fusions may not be good option because of the progression. One of the complication can be happen from the selective effusion of the AIS. It is the adding on phenomena, which is a big concern among the patients, families, and the surgeon. It is a 2-13% incidence, and the risk factor is age, younger patients more, skeleton immaturity, progressive curve, increase in the LIV, CSVL, lower most instrumented vertebra, central sacral vertical line distance of the 10 millimeter distal of the 10 millimeter post-op. The number of the vertebra from the first non-fused vertebra to the L5 vertebra, the NFS, and also the postoperative scoliosis of the lumbar curve, shoulder balance, and selection of the LIV is the most important factors. Wong suggests choosing of the DV, which is the deviated vertebra, first vertebra in the cephalic directions from the sacrums with the deviations from the CSVL of more than 10 millimeter to provide provides the best outcome. They believe that some cases of the adding on may be avoided. As found in the clinical observations, the relationships between the CSVL and the LIV has an important guide significance for the choice of the LIV. Adding on rarely occurs in the linky 3, 4, 5, and C in AIS patient due to the curve or lumbar curve structures. Non-adding on occurred in the patients classified according to the touch type C. So the touch classification has important clinical significance. Determination of the fusion level for the thoracic fusion. Once a patient is determined for a selective fusion, the next step is to determine which level need to be fused. Selection of the ideal lowermost instrumented vertebra is a crucial in preventing distal junctions problems such as adding on or distal junction kyphosis. It's still important to retain as many mobile level segments as possible. Goldstein noted that the fusion should often be extended to a neutral vertebra in V to prevent the further adding on of the curve. King identified the stable and the neutral vertebra SV and NV as the approximate area to end the fusion for a false double curve, double measure curve. Majority of the studies have shown satisfactory outcome when the LIV is a stable and a neutral vertebral SV and SV and NV. One study showed a significant increased risk of the lumbar decompensations when the fusion did not end at the stable and neutral vertebra. The decompensation occurs in a rate of 22%. There are some patients with Linky 1C that have a significant preoperative trunk shift towards the left side. This means that the stable vertebrates by the centered sacral line is located around the thoracic apex, and ending the fusion's contrast around the thoracic apex should lead to poor outcome. In these situations, Goldstein recommended is ending the fusions at the neutral vertebra or one vertebra distal to the neutral vertebra, may an options for the selective thoracic fusion, not extend the fusion to the lower lumbar spines and retain mobile lower lumbar spine. Other factors which contribute to the LIV, including the sagittal balance, the patient's skeletal immaturity, sagittal kyphosis at the thoracolumbar junction T10 to L1 for less than 20 degrees, and the lordotic disc angles below the LIV is important to prevent the distal junction kyphosis. Closure of the triradiate cartilage is important to prevent adding on and distal junction problems. Selection of the uppermost instrumented vertebra is also important for the shoulder balance and the proximal junction kyphosis. Standing shoulder balance, left high levels and right high structures of the proximal thoracic curve, sagittal thoracic kyphosis, T2 to T5, instrumented technique. If the left shoulder is higher than the UIV, should be higher than the UIV should be T2 in the Linky 2C curve, or two vertebra proximal to the upper end vertebra in the Linky 1C curve. The reservation of the thoracic kyphosis or an intraoperative increase is important to prevent the proximal junctional kyphosis. Surgical techniques is also important components to prevent the junctional kyphosis. Distractions of the concave side rather than the compression of the convex side at the UIV is better to prevent proximal junctional kyphosis. We will talk about the touch classification. It is an important risk factor that is highly correlated with the incidence of the adding on phenomenon. It is more qualitative than quantitative way. The best LIV choice to preserve the lumbar activity segments as possible is touch type C. No significant difference was observed in the SRS 22 scores between the touch type C groups and the control groups in short-term follow-up studies. Using the touch C classifications was the best method to prevent adding on and fusion range increased at least one segment in the adding on group. They recommended to choose L4 as the LIV when the L5 is touch type C, and L4 is the touch type B, and the LIV should be classified as touch type C if it is above 4. Classifications and postoperative LAV, which is deviations from the CSVL, are independent impact factors, both of them showing a negative correlation. They classified the regions between the CSVL and the LIV pedicles to 3 types, depending on whether it is CSVL touches the LIV. Type A, B, and C can be used to evaluate the long-term follow-up in the simply way. It is more qualitative than quantitative. CSVL is an important parameter to evaluate the spinal coronal balance. Touch type A, the LIV pedicle does not touch the CSVL, indicating that the LIV deviations from the center vertical lines of the body and the incidence of the adding on phenomena is higher in this type, around 60%. Deviated vertebra is the vertebra that started to deviate from the CSVL. This is a X-ray which shows that it is a 2 weeks post-op. Before it was a less than 10 millimeter. Now it is 30 millimeter with the 4-degree angles. And it is 1 year, it is increased up to 40 millimeters with 10 degrees angle. And it is 2 years increased up to 45 with a 19 degrees. Selection of the lowermost instrumented vertebra. It was subject to more debate research. Wong suggests selection of the DV as the LIV produced the best outcomes and lower complication because it is made to maintain more than lumbar motions and decrease the incidence of the adding on. Matsumoto suggested that the remaining apical vertebral deviations of the main thoracic curve and the last touch vertebra in the cephalic directions of the LIV were significantly correlated with the adding on. Lechal concluded that choice of the LIV influenced and the deteriorations of the lumbar curve and developments of the adding on. It is difficult to decide which vertebra should be classified as LIV, especially in the AIS with the lumbar fusion, because waist activity depends mainly on the function of the L4, 5, and S1. If lumbar fusion included L5 and S1, waist motion is most lost, and the functional activity can be compensated by the lateral hip. The quality of life is a different for patients who has more active segments. The patients with a lumbar fusion LIV selected is a critical. The postoperative quality of life is decreased due to the extended fusion range, and suitable LIV may resolve this condition. The choice of the LIV is based on the analysis and careful studies for the anteroposterior posterior coronal and lateral sagittal range of motions seems to prevent the development of the adding on phenomena. The incidence, as I mentioned before, it is a 2 to 13%. My conclusion and home message is the surgical treatment of the AIS provides excellent patient's outcome and prospective quality of life to heal the scoliosis progression, maintain truncal balance, maximum correct the 3D deformity of the scoliosis. Selective fusion of the double curve is a durable procedure with a later risk for the progression of the uninstrumented secondary curve. Minimize the fusion levels, avoiding the best SFAIS complications, adding on phenomena, further extension and revision. Thank you for your attention.
Thank you very much, Khalid. It's a difficult subject and great presentation. Now we're gonna shift to our next speaker, and I'm honored to have Mr. Walid Hakel. Mr. Walid Hakel is a consultant pediatric and adult spine surgeon from James Cook University Hospital, Leeds, Middlesbrough, UK. And Walid, could you proceed with did COVID-19 era have affect the delayed presentation of scoliosis? Thank you, Walid.
Dr. Walid, you are muted. Kindly unmute yourself.
Right, can you hear me now?
Yes.
Great. So thanks a lot, Professor Yusri, for inviting me and my friend, Dr. Khattab. And yeah, you can see behind me is the sea. I'm actually in Mallorca now, but I'm very honored to be with you today. My talk is about the effect of the COVID-19 on the late presentation of adolescent idiopathic scoliosis. As you all know that we have got a robust system, the NHS system for referral of patients with pediatric spine deformities. And they got referred to us either by the pediatricians or general practitioners, physiotherapists, pediatric orthopedic surgeons dealing with hip or knee problems or limb length discrepancy. And when they discover that these patients have got scoliosis, they get referred to the spine clinic. As you're all aware, we do not have a school screening program in the UK. However, because of this increased awareness of the problem, we get all of our cases referred early, although we can get some missed cases or presenting late. However, pre-COVID era, the majority of the cases get referred to the pediatric spine clinic in the initial presentation. They're usually having a Cobb angle between 10 and 70 degrees. And then once the patient got referred to us, the management will be based, as we all do, based on the same criteria: the skeletal age and the maturity, the curve magnitude, the riser sign, the radiate cartilage, and the curve progression. But also the system for the follow-up, that all of these cases will be reviewed within 6 months of the initial consultation in order to monitor the curve progression. So as we all know, we are talking about a pandemic. It affected us all, affected all of the spine centers and other specialties all over the world. Affected patients, surgeons, and care team members. In UK, we had from March 2020 our first lockdown. So the pediatric spine service was fully suspended for the elective service, both pediatric and adult spine surgery, including the outpatient clinics. And only the emergency procedures were undertaken: the tumors, the trauma, coda equina, and so on. All of the rest were fully suspended. And that has resulted in a backlog of new cases, which waited for a period between 6 to 15 months from the initial referral by the GP or the pediatrician in order to be seen in the spine clinic. Also, those patients, our patient that we have seen before, and we started observation or bracing to be seen in 6 months, they have to be waiting for more than that to be seen, more than the 6 months routine follow-up. All of that has resulted in delayed presentation of the initial cases, curve progression, and delayed intervention for the cases that we know about. That effect of the delayed surgery, we know that it affects the patients based on different criteria. So those patients who are premenarchal with an open triradiate cartilage and a riser 0, who had a delayed surgery more than 6 months, they risk clinically significant Cobb angle progression. This is statistically greater than their more mature peers. So the skeletally mature patient do not progress rapidly, allowing elective time of surgical intervention. Although I will show you in one of the cases, and as is shown in some of the studies, that the curve magnitude is the most relevant predictive factor. One of my cases was the riser 5, which I'll show you, and he progressed badly in a short period of time, although that the patient was skeletally mature. And that confirms this study that the curve magnitude is the most relevant predictive factor. We know that delayed intervention is associated with needing additional surgical procedures, prolonged operative time, greater blood loss, increased likelihood of adverse events. We might need 2-stage procedures, as mentioned earlier about Joseph, about the preoperative skeletal traction and intraoperative skeletal traction, which I've done in some of the cases, and I'll show you that. So we started that concept of safe return to elective surgery. So once they gave us the green light to start seeing our patients in outpatient clinic and operating on them, then we have to do some sort of prioritization of the patients and weighting the risks of the intervention as well as the risks of delayed intervention. So we cannot categorize all of the patients the same. Idiopathic scoliosis of a 50-degree as a completely different case from a neuromuscular with a 75-degree curve and 30% pelvic obliquity and other medical comorbidities. So we have to get this balance between the risk of delaying the deformity procedure against the risk or the frailty of the patient of catching COVID and getting more complications. Once we had the go from the trust to start our service, so post-COVID era, these are 19 cases, which, as I said, completely different from what we have seen before the COVID in every aspect in terms of the curve magnitude, the curve progression, and the Cobb angles that we have operated on. So there were 19 patients all in total after the first lockdown and between the first and second wave and after the second wave. So there were 19 patients with an average age of 14.2, range 12 to 18, and this is their classification according to Linke. All of these patients had a single stage posterior only approach, although they're all big Cobb angles, as I'll show you. It all had one approach, a single posterior surgery two of these cases required preoperative halogravity skeletal traction, as was shown earlier, and intraoperative skeletal traction. And I did asymmetrical pontiostiotomy to all of these patients with the resected bone from the convex side more than the concave side, creating non-parallel gaps. I use uniplanar screws in all of them, and the rods that I've been using now over the last 4 or 5 years are called the transitional rail rod, and I do the differential rod contouring and the correction technique with a combination of derotation, translation, and finally decompression, distraction, and the fine-tuning. So this is the transitional rail rod. I use a titanium transitional rail, and the 5.5 millimeter transitional rail is as stiff as 6.5 millimeter stainless steel. And the idea of being the transitional, because when I initially used the full rail, I had some cases of PGK. So the idea of having this transition between the rail part of the rod to the beam part of the rod, the circular part, is to do this gradual transition of forces, and then that will theoretically, and what I've seen clinically, also reduce the risk of PGK. I use differential rod contouring, similar technique, and the good thing about this transitional rail that you do not see this flattening that you see. I use the cobalt chrome, and I see flattening with cobalt chrome, the normal beam rod. This rod is very rigid, but also we know that the risks of the rigid rod versus the chance of pulling out of the screws, but I use all of my screws as reduction screws. I don't use long tab screws or extended tab screws, because the system I'm using with crickets, I can do this gradual transition of force, what they call the piano key thing, and gradually transforming the forces all the way from one vertebra to the other with a segmental derotation maneuver, and using the convex rod also to push on the convex side. So I'm pushing from the convex and pulling from the concave, as has been showed earlier. So this is the technique that I prefer to use. And so that's the first case. Case number one, a 15-year-old girl, riser 1, looked initially what looks like a Linky 1B curve, 70-degree right thoracic, 58-degree left lumbar curve, and showing all of the criteria with the shoulder asymmetry, slight pelvic tilt, and rib and loin humps. So I put her on the waiting list pre-COVID, and then 8 months after the initial presentation, she came like that. Progression of both curves, now it looks like a Linky type 3. The Cobb angle now has increased to 98 degrees right thoracic and 88 degrees left lumbar curve. But also look at her in the sagittal balance. She has a big positive sagittal balance, thoracic hyperkyphosis, and SVA of 9 centimeters. So that's what I've done to her. T2 to L4, 5-level asymmetrical pontiostiotomy with the transitional rail rods and differential contouring with all uniplanar screw constructs, and I've achieved good reduction, I think, with AP and lateral views with correction of the shoulder imbalance and the pelvis, as well as the big truncal shift. And also, more importantly, is the sagittal balance. And that's what I like about this rod, that I can do the lengthening of the posterior column, because as we all know, you either shorten the anterior column or you lengthen the posterior column to restore your sagittal balance. But I'm starting already with a hyperkyphotic situation, so that was easy to correct sagittally. The second patient is this case, a riser 4, 14-year-old girl. This is something that I did not see pre-COVID. Somebody coming through the NHS with her initial curve, 104 degree and 84, a Linky type 3, a big double major scoliosis. And that because a delayed referral from the point of referral to the point of review for about 14 months. And it was, I normally use the bolster, the bending on a bolster. I don't use the normal bending technique. I prefer the bolster. And she was showing rigidity in both curves. So that's what I've done again, single stage posterior correction, T2 to L4, 6-level asymmetrical pontiostiotomy, again the transitional rail rod and differential rod contouring, and achieving good sagittal and coronal balances. Case number 3 was, again, that's what I mentioned earlier. So he's a riser 5, he's skeletally mature, he's 18-year-old boy, and with a Linky 1A curve, and a Cobb angle was 78 degrees, placed on the waiting list. And this is only 7 months later. The curve has progressed to 101 degrees. So you would expect this not to happen in a riser 5, but as we mentioned, that the curve magnitude is the most predictive factor for curve progression. And you can see that curve, and then again, it was quite rigid, especially the thoracic curve with the bolster view. So that's what I've done again, same technique, and achieving good correction in both sagittal and coronal plane. This is also an interesting case. That boy, the last case, this one, 14-year-old boy, riser 3, seen 12 months again after the initial referral. So he came with a COB angle of 103. Placed on, so all of the cases we have seen after the COVID were all like that. I've been seeing all of the figures, hundreds and so on, not seeing the small figures that we used to get before. So I put him on the waiting list, and then he has been lost in the gap between the first and the second waves. 7 months later, he came with this big angle, 145-degree curve. So I put this patient on the halo gravity traction, discussed by Joseph earlier. So I put it only for 3 weeks. Halo gravity traction, I agree that with the literature, what he mentioned that most of the correction you achieve within, actually, it was within the first week. So I agree that you get most of the correction in the first 2 weeks. I put him on the halo gravity for 3 weeks, and I started by 9 kilograms. He was 45 kilograms. So you can start with 20% of the body weight with neuro observation. As you see, you can put it on the wheelchair or on a walker, so it's not necessarily to keep the patient in bed the whole period. And this was in hospital. It was not at home. He stayed in the hospital for 3 weeks. Then I did a chest X-ray. This was taken 1 week after the traction. So you can see that there is achieving good correction with the halo. So that is chest X-ray in bed showing correction. But once you take the weight off, then you almost lose all of the correction. So I did it after that with intraoperative traction. So when I took the traction off and I took an X-ray in theater, I found that he was going back to square one. So I kept the traction on with the monitoring, and I did the exposure, because otherwise you would never be able to reach the convex side of the curve for exposure or even instrumentation. And then I did that. So when I was listening to the previous talk about instrumentation, traction, and then or release, and then putting the rods, no, actually I did that, and in another case, all in a single go, and I did not need to do it as a stage procedure. Maybe I was lucky in that sense, but it's something that you can discuss. But I think we have achieved good correction in a single stage procedure. There was no issue with the monitoring. The only thing that I feel a bit worried about is the traction after the release. I have seen two cases done in a different center where they had the release, and then they had the traction, and they got paralyzed. I'm not sure about how safe it is to do the traction after the release without monitoring, especially that if you leave the patient in the ward. 2 cases I've seen, because we have in our hospital one of the major spine injuries unit, about 7 or 8 in the UK, and James Cook has got one of them. So we get all of these cases getting transferred to the spinal injuries units, even done at different centers. And these 2 cases were one of these tragic stories. So I personally do not do this traction after the release. I get worried about that, and I prefer to do it all in a single stage. And that is a good sagittal balance following the correction. So as a discussion, COVID-19, as we all know, has resulted in delayed presentation of the scoliosis cases. We are now seeing figures that are maybe normal to be seen in Egypt or in India or other centers. Definitely, you can see this a lot. But in UK, it is not something that we used to see before the COVID. As you see, the COB angle median was 98.5 degrees. And they're having a low bending flexibility index, but we have achieved a 78.8% scoliosis correction, which I think is a good figure. And we have used a single posterior approach to all of these cases. I think that the use of rigid rods, as well as the asymmetrical Ponti, I didn't need to do any VCRs or PSOs, all just the Ponti. Multiple Ponti at both curves if it is a link 3, and in some cases the preoperative halo traction are valid option for extremely rigid curves with a high magnitude. So the posterior only procedure, I'm not giving here a new message. It's been done before, it's been studied before, that you can do it all as a single stage procedure, and especially for those patients presenting late following the COVID pandemic. And using this technique can eliminate the need for the anterior release and the associated complications with the anterior surgery. Thanks a lot.
Thank you so much, Dr. Walid, for your interesting presentation. And the next speaker will be Dr. Abdullah Shah. Dr. Abdullah Shah, spine consultant working in Gorky Trust Hospital, Lahore, Pakistan. Dr. Abdullah will present neural axis abnormalities, when to intervene. Dr. Abdullah.
Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh.
Yes, Dr. Khattab, how are you? Yes, Assalamu alaikum to everybody.
I am fine,
Yes.
brother. Please
yes.
go ahead.
Now, yes, I am going to discuss spinal cord anomalies in patients with scoliosis. Just let me start. Bismillahirrahmanirrahim. Our learning objectives are varieties of congenital or acquired anomalies associated with scoliosis and significance of various pathologies dealing with cause or effect on scoliosis and rationale for management, whether to decompress or whether to go without decompression for definitive surgery. There are various types of anomalies. You can have spinal axis anomalies and extraspinal anomalies. In spinal axis anomalies, you have diastematomyelia, tethered cord syndrome, syringomyelia, Arnold-Chiari malformations, spinal tumors, and in extraspinal anomalies, you have cardiopulmonary complications and anomalies and genitourinary anomalies. In last 2 years, we concluded we have evaluation of MRI done in our scoliotic patients. We gathered data of 87 patients, 56 were idiopathic and 31 were congenital on X-rays and history. And these pathologies were found here: diastematomyelia in 4 patients, tethered cord 2 patients, syringomyelia, tonsillar ectopia, osadontodym, Arnold-Chiari, hydromyelia, dural ectasia, and dural defects. These 8 types of pathologies are found in these patients. And you know that diastematomyelia, which was the type 2 in idiopathic, it was 1, and in 3 patients of the congenital scoliosis, we found 3 patients have diastematomyelia, and syringomyelia were in 5 patients in both the varieties. Now I will discuss every pathology in separately and in a bit detail. So first, the diastematomyelia, it is the most common pathology found in the congenital scoliosis. It has different types, type 1 and type 2. In type 1, it is a fibrous cartilaginous or osseous bar creating a longitudinal cleft in the spinal cord. And usually it occurs between T9 and S1 level, and most common in upper lumbar region. Types, there are 2 types. Type 1, it is classic type 1, in which there is a duplicated dural sac, there is hydromyelia associated with this defect, and there is a midline spur, which mostly is cartilaginous or it is bony. And there are associated vertebral anomalies, hemivertebra, butterfly vertebra, or spina bifida, and usually it is symptomatic, I mean scoliosis and symptoms of tethered cord. This is grammatic presentation, having a spur in between and then double sac. The type 2 is milder form. It is single dural sac and there is no spur or septum in between, cord divided, and then sometimes it reunions. And there is hydromyelia and there are vertebral anomalies and symptoms. There are less in this category. So type 2 and there is not complete division, but only there is 2 sacs, but there is no fibrous septum. This is some presentation of diastematomyelia. There is spur in between, and there is, you can see MRI of the diastematomyelia. Another variety is diplomyelia, in which there is a doubling of the cord. There is no reunion, just there is the division of the cord, and cord run whole way in double fashion. There are some associated anomalies along with the diastematomyelia. There is meningocele, neuroenteric cysts, dermoids, spinal cord lipomas, hemangiomas. They may be have associated anomalies along with the diastematomyelia. And symptoms may be asymptomatic totally, or it may present with leg weakness, low back pain, incontinence, or it may present with club feet. Now the imaging. In case of you can have diagnosis in utero with ultrasound, and then in patient with scoliosis, you have you will get X-ray of all the patients. So there will be interpedicular distance widening, or there's a spur may be located in the X-ray, and CT will help to delineate the bony pathology, and MRI will again show the doubling of the card. These are some pictures of the MRI. Now the treatment. In asymptomatic patient, only observation is needed and close monitoring. But if you are planning for surgery, so surgery is indicated in patient if symptomatic or has a neurological defect. If patient has neurological loss or some other complication, then surgery of the diastematomyelia is needed. And you must resect diastematomyelia before correction of scoliosis with unstable neurology. And if you are going to operate, duplicated dural sac must be resected and repaired. This is the form of resection of the dural sac, and then it is ready to repair. Now there is some different feature for regarding location of the spur and symptoms. So in JBGS, they concluded that an osseous spur at the apex of the scoliosis may be related to high risk of developing a neurological defect, especially in patients with kyphotic deformity. So if there is a kyphosis associated with scoliosis and the spur is located at the apex, there is high risk of neurological deficit during intraoperative surgery for definitive fusion or otherwise also. And again, in JBGS, it may be safe to leave diastematomyelia untreated in patients with intact or stable neurology. So if the patient is having no neurological loss, neurology is stable, patient is asymptomatic, you can safely operate scoliosis regarding definitive fusion under neuromonitoring. Again, a paper from China indicate that bony spur need not to be excised before spinal correction if there is no sign of spinal cord tethering and the bone spur located in the middle of the split cord where there are much space to accommodate. So in a nutshell, if there is no symptoms, you don't need to decompress the this diastematomyelia. But if patient is symptomatic, you need to decompress it and then do the corrective surgery. Next is the tethered cord syndrome. Tether, what is tether? It is stretch-induced functional disorder associated with tethering effect of inelastic tissue on the caudal spinal cord. It increased tension with aging lead to neurological deficit, and there are various causes. First is tight filum terminal, lipomeningocele, diastematomyelia, closure of spina bifida, and dermoids. These all pathologies can cause tethering effect. There may be lesion, hairy patches, dimple, fatty tumors, foot and spinal deformities, weakness in the legs, abnormal gait, low back pain, urinary incontinence. These features are associated with tethered cord syndrome. In children, there may be skin stigmata on the skin. You can have some dimple or some nevus or something like that. And in adult patients, they may present with severe pain, back pain related to legs and groin. There may be sensory or motor loss, maybe urinary incontinence, bowel or control problem may be there. Diagnosis. MRI is the gold standard, which shows the conus medullaris level. It is below from normal level, which is from normal level is L1 and L2. So it may be lower. And then NCS NEMG for nerve function. But usually it is a clinical diagnosis, and radiological aid is helpful for making decision. The treatment is supportive treatment for pain, Early surgery is important before the patient develops some neurological deficit, and detethering surgery is must before doing any corrective surgery. So laminectomy and then excision of falum terminal in selected patients. And sometimes if there are adhesions or you opt not to address the tether cord, you can bypass it by shortening the column with various osteotomies. This is the presentation of pre-op picture regarding tight falum terminal and then resection of terminal and adhesions. The third variety, which is most common, we can come across with the idiopathic scoliosis or congenital, which is Chiari malformation. It is a condition in which the lower part of the brain, the cerebellar tonsil, herniates down through the skull and into spinal canal, blocks the normal flow of cerebrospinal fluid. And this is the presentation diagram. You can see that this is the cerebellar tonsils coming down and compressing the spinal cord. And here is the MRI of the Chiari. There are 4 types of Chiari. Type 1 is the herniation of cerebellar tonsils only. Symptoms of syringomyelia will be there. And type 2, there is herniation of cerebellar vermis. Vermis along with the fourth ventricle and medulla. Sometimes they come into the spinal canal. And it may be associated with the lumbar myelomeningocele. And type 3 is occipital encephalocele, where there is meningocele at the occipital region, usually associated with tether cord or hydrocephalus. And type 4 is when there is no cerebellum at all. There are the grammatic presentation, type 1 and type 2. This is type 1 with only downward placement of the cerebellar tonsils, and type 2 with the displacement of the fourth ventricle and brainstem and the spinal canal. The presenting symptom will be pressure-like headache at the back of skull that worsen with physical strain, hoarseness or swelling, sleep apnea, weakness or numbness in the extremity, balance problems, headache in the neck of the head, and worsen that worsen with coughing, sneezing, or straining is a hallmark sign. The treatment, if symptomatic, it is decompression. The next one is syringomyelia. It is a fluid-filled syrinx formation within the spinal cord and can progressively elongate. And in juvenile scoliosis, with 50% of the curve, it is found that there is a syrinx association, and it causes rapid progression of the curve. It may cause mass effect with upper motor neuron damage, and it is mostly or usually associated with Chiari malformation. The causes are Chiari malformation, fourth ventricle communication, basal arachnoiditis, meningeal carcinomatosis, spinal cord trauma, spinal dysraphism, or sometimes it can be idiopathic. This is a diagrammatic presentation, cerebellum coming downward and pushing, and then there is secondary syrinx formation here. Depending upon the connection with fourth ventricle, it may be communicating, non-communicating, or it may be extracanalicular outside the arachnoid matter. Symptoms and signs of syringomyelia. It causes chronic cape shawl-like back pain, associated sensory loss of pain and temperature, asymmetric deep tendon or superficial abdominal reflexes, unilateral or bilateral muscle atrophy and weakness. This is cape shawl-like distribution of pain and temperature issues. Investigations, MRI is the gold standard for diagnosis, electromyography for muscle weakness, and CT to evaluate the pathoanatomy of if there is any tumor obstructing the flows, the normal flow, or some other pathology. This is MRI picture. Management. So syrinx may need decompression if it is symptomatic, and also try to find the cause of this syrinx. If it is Chiari, deal the Chiari, or if there is any other thing, tumor or something else compressing the cord and causing secondary syrinx, then treat the cause. And then if patient present with early scoliosis, you can brace or you can do corrective surgery with or without syrinx decompression. You can do shunt operation. You can do excision of the tumor, and you can do sub-occipital craniotomy for carry malformation to decompress the carry. So management, syrinx decompression can stop progression of scoliosis and even can reverse or treat the flexible curve. So if patient comes with flexible curve and there is syrinx, you need to deal with the syrinx, and if you decompress the syrinx, patient may recover her deformity. So there is a paper from Journal of Pediatric Orthopedics showing that 48% of the cases in which the decompression was done, their progression of the curve stopped and they recover. And only in 31% of the patients they need surgery after syrinx decompression, surgery for deformity. Now the last few slides. Spina bifida. Spina bifida is a birth defect that occurs when the spine and spinal cord don't form proper. Normally, the neural tube forms early in the pregnancy and it closes by the 28th day after conception. In babies with spina bifida, a portion of neural tube fails to develop or close properly, causing defect in the spinal cord and in the bones of the spine. This is the picture of spina bifida when there is loss of posterior elements. It may be spina bifida occulta, or it may be present with meningocele or with myelomeningocele, which is the most severe form in which meninges as well as neural tissue comes out under the skin. Now, take-home message. Always get MRI in scoliosis patient planned for surgery for occult pathology. If patient present with diastematomyelia, if it is asymptomatic, proceed with scoliosis correction under neuromonitoring. If it is symptomatic, meaning that there is some neurological deficit, resect the diastematomyelia first and then do corrective surgery. And if there is tethering, and if tethering is symptomatic, detether first, usually in single stage, detether and then do correction in the single stage. And if there is carry malformation with associated symptoms of syrinx and other things, then always do decompression of the carry. And if patient comes with syrinx, so in flexible curve, you can do only the treatment of the syrinx. It will recover the scoliosis as well. And in mild syrinx with no obvious cause, you can proceed with deformity correction. And if there is symptomatic, treat the syrinx along with deformity surgery in single or two stage. Thank you very much.
Thank you so much, Dr. Abdullah Shah, for your conclusive presentation. And we'll keep discussion till the end. And I'd like to invite our dear friend from Germany, Dr. David Tropisch from Frankfurt. David will present two talks. David will cover vertebral body tethering, an algorithm for management, and some tips and tricks how to preserve the mobility in our adolescent idiopathic patients that have a little bit potential for growth. David, welcome to our Scoliosis Week, and we are happy to hear your presentations.
Thank you very much. We've heard great talks about the standard treatment of scoliosis, and I'm happy to present something new, vertebral body tethering, which is a non-fusion technique, and I believe it has a chance to lead to a paradigm shift. I will start the presentation. It's pre-recorded because I wanted to make sure to stay in time, but I'm here. Hi, everyone. Here are my disclosures. So I want to propose my approach to VBT, and my approach is based on my experience. Just to give you a brief note on my experience, I was allowed to start approved VBT in 2017 when the first device received CE approval. It was approved for all kinds of scoliosis curves and also all maturity statuses. So I have operated a very heterogeneous group. By now, I have operated more than 180 patients with VBT and a total of 250 curves because some of these patients have double curves. We strictly analyzed our results, and I found that those patients where I was not very happy with the results, results were often not based on VBT itself, but maybe on wrong surgical planning and wrong surgical execution. So based on our experience, almost with every patient that we operated, we gained experience, and finally we came out with an own treatment algorithm, which is based on 5 curve types, and which I now introduce to you. But before that, I want to show you why I consider VBT at all. Please look at this young girl. She's 1 year after vertebral body tethering from T5 to L4 for a double curve. She had a double curve that would have required spinal fusion from T4 to L4, maybe L3. But I think many of you would agree that this kind of flexibility would not be possible with a spinal fusion that goes into the lumbar spine. So my main reason for considering VBT for some patients is that I would like to preserve motion. It's a motion preserving surgery. Therefore, I believe doing it for lumbar curves is better than for thoracic curves. We all know that most of the flexibility comes from the lumbar spine. It may modulate growth, so doing it for very young kids is nice, and you will change the shape of the bone, which is the second preference. And just the fact that it's less invasive surgery doesn't really play a role for me. So these are the curve types that we have defined. Type 1 to 5, and it goes from left to right. And on the left side is the curve that I highly recommend VBT for. And then stepwise, the recommendation decreases all the way to the right, and the curve on the right is the curve that I don't recommend VBT for. On the left side, type 1 is a classical lumbar curve, and then it's followed by a double curve, type 2. Type 3 is a long thoracic curve, and type 4 is a short thoracic curve. And type 5 is any kind of curve with a structural high thoracic curve. And this classification has an excellent reproducibility, and we were able to present this data on the last IMEST meeting. So let's give a few case examples. Here we have a lumbar curve, a type 1 curve, where the standard treatment would be a spinal fusion of the lumbar spine, or at least into the lumbar spine. And we all know that lumbar fusion takes flexibility, and there's quite a good amount of long-term data that it shows it increases the rate for adjacent segment degeneration. So this is my number 1 curve type, where I believe it's really good if we have it, if we could preserve motion. The patient was almost mature, not fully mature, but a Sanders type 7. I recommend to go by the Sanders hand score. So which means probably only maybe 1 more of growth left, but too much. So I went for a little bit better correction. So we brought it on more than 80%, almost 90% correction. And she lost some correction at the 6 months follow-up. And if you take a close look between the bottom 2 screws, the angle changed. So this is an indirect sign for a cord breakage. And she probably broke her cord between L2 and 3. But even though she broke her cord, she still has a nice outcome at 12 months post-operatively with a well-controlled curve, well below 30 degrees. And also she has a nice sagittal profile here. We found that if you use a single cord, there's quite a risk for an early breakage of the cord. So I changed my technique, and for type 1 curves, I now put in 2 cords, which you can see all the way on the right side on the lateral view. We have 2 cords right next to each other, at least at the bottom part or at the apex. And we found that putting in 2 cords instead of 1 delays cord breakage. It will not prevent cord breakage, but it delays it, and the spine has more time to adjust to the new position and to have some tissue remodeling. So here's a type 2 curve. So that means a double curve, 2 curves that deviate from the midline. The reason is the same. This girl will probably require a fusion down to L3 or L4. So the reason of motion preservation and the goal of motion preservation is the same. but it's a type 2 because it requires a double curve VBT. I don't recommend selective VBT. The patient was also very mature or close to maturity with a standard 7 RISA 4. She was very flexible. This is her first erect curve, so we went for a good correction. And this is a reason why we do it. This is only 6 weeks post-operatively. And as you can see here from her smile and from her motion, she was very flexible, very short recovery period. So I'm going to continue. This is her 12 months follow-up. This is her 24 months follow-up. And even though she was almost mature with a RISA 4 and standard 7, 2 years after surgery, I believe we have a fantastic outcome. So for the double curves, I just as an example, for the lumbar curve, I now put in 2 cords to have it a little bit more stable. For the thoracic curve, I still only put in 1 cord because the vertebrae are smaller, and also 2 cords are not required for a thoracic curve in my eyes because you have the stabilizing rib cage. This is a double curve that I operated in the wrong way, I believe, because I went for a selective VBT. She was very young, RISA 0, standard 3, and she did not continue to growth modulate her thoracic spine, but she just added her lumbar curve. And I believe that that rebalancing was an issue. So her lumbar curve just continued to get worse, and I had to revise her. And this is her 12 months after revision with a nice balanced curve, 2 cords in her lumbar spine, 1 in the thoracic spine. And this is why I believe that a double curve needs a double VBT. This is one example for it. That's why we have the classification. This is a long thoracic curve, as you can see here. And this is also a long thoracic curve. The one on the left had vertebral body tethering, and the one on the right had spinal fusion. And I think you would agree if I say, well, spinal fusion gives a great and fantastic coronal and maybe even sagittal, but especially coronal curve. But if you look at this, there's a difference between motion at the thoracolumbar junction, and I believe preserving this thoracolumbar motion is really important because it's a very important compensatory mechanism later in life. So this is a short thoracic curve, our type 4. And for this kind of curve, I usually go for spinal fusion. This is one example where I went for a VBT. And it's nice to see that this patient increased kyphosis in the thoracic spine. But usually I say, if it's not a too young kid, why not go for a fusion? But there are instances, and you will see that later on another slide, where I believe it's good that we have VBT. This is a high thoracic curve where I don't recommend VBT because then the patient will end up having a huge shoulder elevation on the left. And this is just too high for VBT. You cannot get to the upper thoracic spine by VBT. So what did we learn over the course of these 250 tethered curves? I stopped doing selective VBT. I don't have good recommendation. I don't have a good experience with selective VBT. I recommend 2 cords for thoracolumbar and lumbar curves to delay cord breakage. It will still break, but you can delay it and give the tissue more time to modulate. We also found tips and tricks on level selection, but level selection is actually a difficult topic, and today we don't have enough time to discuss level selection. Let's go to the next one. And then with this curve classification, we came up with some kind of table. You don't have to look at the details, but just look at the left column. Here are the curve types, type 1 to 5. And look at the bottom row. On the first row, this is the flexibility. The first one is it bends to less than 30 degrees, then it bends to less than 40 degrees, and not flexible, bends to more than 40 degrees. So if you have a curve that's all the way on the left and on the top, it's a good candidate for a VBT. If you have a curve at a patient all the way at the bottom on the right, it's a bad candidate for VBT. And to have it a little bit more I have this slide. It's a little bit complicated if you look at it first, but if you have it in front of you in the table in the office, when the patient comes in, it's actually not that complicated. You just look for the first type first. Let's say someone comes in with a double curve here, and then we have 3 options here. And then it depends on the flexibility, which option we choose. Or if he comes in or she comes in with a type 4, we have 4 options. And this will evolve as we get more, more experience and information and data. But this is what we have right now, and it is a huge help for me to decide if I want to go for VBT, if I want to go maybe for a growing rod, or if I go straight to a spinal fusion, if I go for 2 cords or 1 cord, if I do selective or double VBT. I think this slide helps me a lot. I hope to give you more information about our treatment algorithm in the future. I thank everyone for listening. This was just a very short introduction of how we approach VBT in Germany, in Zimmermann.
Thank you very much, Dr. David, for your.
So, can you hear me? Yeah, right. I don't hear right now, but I'll probably just continue with my next talk if like it's planned.
Yes, please continue.
1 second, I have to find it.
Yeah. Yes, please, David, go.
Okay, I think I have to stop sharing first. I'm going to close this one. 1 second, I have it.
So here's my second talk. Again, it's a great pleasure and honor. And now I would like to talk a little bit about the surgical technique and maybe a few tips and tricks for vertebral body tethering. Everyone does it a little bit different, and you will see different techniques when you hear these talks. A few surgeons do it purely thoracoscopically, but I actually prefer a combination of a mini thoracic technique and thoracoscopic surgery. So what we usually do, we have 1 or 2 apical 5 centimeter or 6 centimeter incisions, plus 1 or 2 thoracoscopic portals at the end, like you can see here. On the left side, you see how I position the patient, strict lateral, and I mark midline of the spine, and I mark my first incision. In the middle, you see how it looks like for a long thoracic curve, let's say a T5 to L2, for example. Usually we do this combination of 2 thoracoscopic portals and 2 mini open approaches. And on the right side, you see a shorter thoracic instrumentation, maybe T5 to T11, for example. So let me see, this is how I do it. I have to start the video here. My direct view in combination with a thoracoscopic view, I look for the rib head, and just in front of the rib head, I cut the pleura. I try not to cut the segmental vessel, and I just take my bipole, and then I coagulate the segmental vessel, which is totally fine. I don't clip it or so. This is in real time, so it's quite fast. And then I expose the lateral wall of the vertebral body. I open the pleura just so that I have enough room for the staple. And then by anatomical landmarks, without any X-ray, I put in my staple. Usually I put in a few staples, and then I get a lateral X-ray to see if I'm in the spinal canal, or if I just like my position on the lateral X-ray, like this. So it is possible to save segmental vessels, but usually I don't do that actually. But if you have a reason, for whatever reason, maybe you, from the other side, you cut it already, and then it's possible at least. So once you have the staples in, then by AP X-ray or by AP fluoro view, you prepare your screw hole and you want to be bicortical. So you have that all, and you can measure the length from there and make sure you're going in bicortical to have a stronger screw. And then you just put in your screw. It's nice if they are parallel to the end plate, but they don't actually have to. So here on the right side, you see how it looks like if you do it purely thoracoscopically. You have 3 thoracoscopic approaches, like you can see here from the red lines. And then the screws are not perfect parallel to the end plate, but this is okay. But again, now as I do mainly mini open approaches, the screw usually look very parallel. So there's another advantage of doing it mini openly, and which I want to show here. So now we have a situation where all the screws are in place, and I've seated the cord into the screws already. So the correction is a combination of screw tensioning, and there are different devices. Currently, we have in Europe we have 3 CE approved devices, and each set comes with different option for tensioning the cord. But another important step for correction is derotation. And just look at this video here. These are the screw extenders, and I derotate the apex. And then my assistant will compress by using the screw extenders. And then you have most of the correction already. You check on X-ray, and then after that, you tension the cord. But because you do the manual correction first, there's not so much stress on the cord. So let's go to the other side. On the left side, you very often have thoracolumbar and lumbar curves, which is a little bit different because, at least for me, I approach the lumbar spine by a mini open retroperitoneal approach. So this is how it typically looks like. On the left side, you see my marking of the midline and then my first incision. My first incision is usually below the 12th rib. So maybe lateral to L2 or L3. And then the other incision on the right side, you see usually lateral to T11. And if it's a very long curve, you can also add a thoracoscopic portal that you can see here all the way on the top. So you can expose the spine all the way down if you wanted to L5, but this is a little bit more tricky. Usually my lowest instrument for VBT is L4. And then I go anterior psoas, so you retract the psoas, so there's no injury to the nerve root. And this is how I put in the cord, and I have to explain it a little bit. So we are looking, this is a thoracoscopic view on L1. We are looking right down through the chest. And on the left side, you see the diaphragm, which is retracted with a retractor. On the bottom is also the diaphragm. And let me start this video. And I go with my curved clamp into L1 and aim towards L2. Now we change the view. We're looking at the L2 screw. And I come out through the diaphragm and the L2 screw. And I open this. And then I grab the cord from the retroperitoneal space, like here. And we change the view again. And now I pull it up into the chest through the diaphragm. And the opening in the diaphragm is maybe only 1 or 2 centimeters. And there it goes. So the advantage of this technique is that you don't have to detach the diaphragm and you don't have to expose the spine, the lumbar spine from the chest, which is really nice, and recovery is very fast. So I want to give you a few examples for a lumbar retroperitoneal approach. So here we have a classical Lenke 5, or in our classification, it's a type 1 curve type. So a very good one to do VBT. As you can see here, she has severe trunk shift, and you see the waistline, which is very asymmetrical. Let's go to the next slide. She's very flexible, so her curve bends down to less than 30 degrees, and she's She's RISA 2, SANDA 6, so she's past her rapid growth spurt, but she still has some time, maybe more than a year or so. So for me, this is the perfect candidate because we don't want to fuse her, and she's a good candidate for VBT, although we don't have any data. So this is the first direct. She still has a little bit of tongue shift. And this is 2 months later, and very well balanced, good controlled curve. And as she will grow, she has a chance to correct a little. And as you can see here, for the lumbar curves, like I said in my first talk, I usually use 2 quads now to have a little bit more time before the quad breaks. And this is the mini open approach. It looks long, but just because the girl is a little bit small, but look at my thumb. So the incision is not longer than my thumb, and I don't have a huge thumb. So two incisions, one in the middle is from the chest tube. I didn't use a thoracoscopic portal for this one, just for the chest tube. And this is the reason why we do it. Because we preserve motion, and this patient is very flexible.
Thank you very much.
Thank you very much, Dr. David, for your very nice presentations. And can we now move to our last presenter?
Not sure if I can hear you.
Bilal Nadi from Asyut University. Dr. Bilal.
I don't think I hear you. Can you?
We will proceed for the last speaker, Dr. Bilal Nadi, and we'll keep the discussion after the last speaker, Dr. Bilal.
So, good evening, everybody. From Asyut University. Firstly, I would like to thank my dear professors Yusuf Al-Hawari and Mohammed Fawzi Khattab for this kind of invitation. I really would like to join you as good evening, everybody. I am Bilal Nadi from Asyut University. Firstly, I would like to thank my dear professors Yusuf Al-Hawari and Mohammed Fawzi Khattab for this kind of invitation. I really would like to join you as a live presentation. However, unfortunately, I'm not able to join at that time. So I will start quickly to speak about my current presentation is about the vertebral column resection and deformity surgery. So I will share my screen and we'll start about vertebral column resection in deformity surgery. Of course, as all of us, just a minute, okay, now it's working. As all of us know that the treatment of severe spinal deformity is always a challenging procedure for spine surgery. And vertebral column resection actually offers the greatest corrective, the most corrective, powerful corrective tool for deformity correction, especially for rigid deformities. However, this procedure is technically demanding procedures with significant morbidity. So if we speak about the history of vertebral column resection, it is an old procedure firstly described in 1922 by McLennan et al. And actually he was describing the resection of deformed vertebra and casting after that. And with the epidemics of tuberculosis In 1965, Hodgson expanded this vertebrectomy for treatment mainly of TB kyphosis, and he described the resection of the kyphus and correction of the deformity of this rigid spinal deformity. And in 1980s, Bradford described the correction the circumferential vertebral column resection for rigid spinal deformity, and used staged procedures, anterior, then posterior, with good operative result and powerful correction for this rigid spinal deformity. And actually, the break in the deformity correction occurred in 2002 with the description of the posterior only vertebral column resection by Sook et al. For rigid spinal deformities. And since that, actually, the posterior vertebral column resection is the gold standard for treatment of spinal deformity. Why it is the gold standard? Because it is a very powerful tool, allows you to resect both the anterior and posterior element of the spine, stabilize the spine through the powerful pedicle screws from the back, and reconstruct the anterior column with whatever you would like, cage, expandable cage, pyramesh, or strut bone graft. And all of this can occur through one approach, which is the familiar posterior approach to all spine surgeries. And since 2002, this has been described in several publications with use, and several studies studied the posterior vertebral column resection for deformity correction. One of these studies was published in 2017, and it was a review article reviewing the result of vertebral column resection over more than 15 years of experience. And the results of this study showed that. Firstly, what about the indication? What is the surgical decision making? When to choose this patient for vertebral column resection? And this study said that vertebral column resection is a complex procedure, should be reserved only for rigid, multiplanar, sharp, angular deformities. This requirement that deserve this big surgery. For examples, is severe neglected scoliosis or hemivertebral resection, congenital kyphosis, especially if it is severe, and you can expand it into post-traumatic kyphosis or in selected cases of vertebral ptosis of L5. And according to this review article, the clinical outcome of vertebral column, posterior vertebral column resection is amazing. It provides about 60 to 80% correction of coronal curves, more than 50-degree correction in the sagittal plane, and this 50-degree correction can be increased into more than 80, 90 degrees of correction, as we will see later in this presentation. However, is the tedious surgery required take about from 6 to 12 hours of surgical operation, and it also there is a lot of blood loss, up to 6 liters in some studies for this procedures. And of course, this powerful correction maneuver is not without the complications or the morbidity. So according to this review, the complications include around up to 9% of surgical site infection, up to 13% of neurological deterioration, some of them are transient and some of them unfortunately are permanent neurological deficits. And we have up to 7% pseudoarthrosis rate due to the long resection area, and many of those patients of pseudoarthrosis require revision surgeries for restabilization and bone grafting. So it is a powerful tool, but with a lot of morbidity. So what about our experience? Our experience in Asset University Hospital, actually we started with the patient with adolescent idiopathic scoliosis, those with severe or neglected curves, and we have combined the minimal vertebral column resection with high density pedicle screws for correction of severe adolescent idiopathic scoliosis. And actually this was the start of our experience. So we used to resect a small part of the vertebral bodies. It is like more or less asymmetrical PSO, and we used bone graft and try to compress at the convex side to close this vertebral column, the resected area, and to have bone-to-bone contact. And if we had a small defect, we would fill it with bone graft, depending on the long fixation above and below. And in this study, we included 14 patients with severe AIS. The mean Cobb angle was 84 degrees, and the average age with around 17 years, so it is a bridged deformity, and we achieved about 60% curve correction, and we are fortunate enough not having no vascular or neurological complication. However, we had a patient with hemothorax. For example, this is a 16 years old man with mean curve of 85 degrees, and we did him vertebral column resection, direct bone contact, and bone grafting, and we have marked correction from 85 degree preoperative to 22 degree post-operative. Another patient is an 18 years old with around 100 degree of dorsal scoliosis, and we operated him with the same vertebral column resection as the convex side, bone grafting, and closing of this with the defect after resection, and we achieved correction up to 44 degree post-operative. So after our initial experience with limited vertebral column resection with AIS, we started another step in patients with severe neglected congenital kyphosis. And actually, this study was published in the European Spine Journal in 2019, and it was a good study about resection and anterior fixation. We added the anterior instrumentation for patients with severe neglected congenital kyphosis. In this study, we included 15 patients. Also, they was around 19 years old. This means that they have a rigid deformity. And mainly this patient has a local kyphosis, more than 100 degree of kyphosis. And this is the main indication. And some of those of our patients were have associated scoliosis. For example, this one of our study is a female patient, 22 years old, and has around 100 degree of both kyphosis and scoliosis. And we did for her posterior vertebral column resection, reconstruction of the anterior defect. We excised 2 or 3 vertebrae, reconstruction of the anterior defect using a mesh cage, and we added this anterior fixation, anterior instrumentation of the body above and below to stabilize the cage, and we have a very good correction both in the coronal and sagittal plane. And in such a deformity in this study, we have 3 complications. One of our patients had CSF leakage during surgery, and this managed by suture and post-operative bed rest and diuretics, and the patient didn't require any revision surgery. Another patient required, it was the severest case in our series. It was also one of the start from our the first case that we operated here, and we used only 2 levels at the first surgery, 2 levels above and 2 levels below the fixation. And this patient had a loose implant that required surgery, bone grafting, and extension of the fixation, and it had also a good correction after this surgery. And we had another patient. Actually, he was the smallest, the youngest patient in our studies, and actually we achieved excessive correction of his deformity, and he had a BGK above the level, the fixed level. And we attributed this BGK to the market correction, which we should not correct at this much level. And actually, he's planned for revision surgery. However, he didn't agree to this revision till now. After that, we introduced another concept of vertebral column resection, which we can call it the wedge vertebral column resection. The philosophy of this wedge vertebral column resection is that in patient with adolescent congenital kyphoscoliosis, so you have a patient with neglected hemivertebra or whatever deformity, local congenital deformity of the spine, it was neglected till the adolescent. So you have combined kyphosis and scoliosis. So our policy, that is our philosophy, is to decrease the operative time. As we know that vertebral column resection, you have to excise the whole vertebra from both sides, the whole pedicles and the whole lateral walls, which take a long time. So we thought that if we did a very good resection from one side, so we remove at like wedge closing osteotomy, we remove the vertebra, we attack to the level of the market kyphosis, and the convex side, we start at this side, and then we remove a big wedge, and we try to close this wedge in order to save time, preserve some stability of the spine by keeping the other cortex of the vertebral body intact. Actually, from the other side, you can crack it a little bit to be soft and to be malleable during correction, but we don't dissect the other cortex. We do not excise the whole other side. And we said that we thought that if we did this from one side, good dissection both from the convex and the posterior element at the kyphosis, we can get a lot of correction, a good correction with less aggressive vertebral column resection. And we applied this to a 19 patient, and we achieved a very good result, about 60% scoliosis correction and 70% kyphosis correction, and we reduced the operative time from 7-8 hours in the formal vertebral column resection to about 4 hours in this procedures. And thanks to Allah, we don't have a neurological complication, but we have a radiological BGK because we operate a patient at younger age, around at the adolescence, and we still, till now, we have no revision, just radiological BGK without symptoms. And the examples are like that. For example, this patient, he had both congenital kyphosis and scoliosis at the L1, and we went from the left side, the convex side, posterior, and the left side, we resected a wedge and tried to close this wedge to correct both kyphosis and scoliosis, and result is fine. And actually, if we closed this wedge and we had achieved bone contact, so it's enough. If there is still a gap, we put a small mesh cage instead of resection of the whole vertebra and putting a large mesh cage. Another example for this patient with a kyphosis, neglected congenital kyphosis, and again, we'll go from one side, wedge resection, vertebral column resection, and we put a small mesh cage just after closing this wedge, and with good post-operative result. Another one is a male patient, 19 years old. He had also neglected adolescent congenital kyphoscoliosis, with mainly kyphosis around 80 degrees, scoliosis around 70 degrees, and the same principles, which is wedge resection from the posterior and convex side, trial of closure, and small mesh cage to have a good contact. And actually, at this study, we are very satisfied with the result: less operative time, more stable spine, and shorter defect that closed with a small pyramesh or mesh cage with rapid healing of the construct. And we had in this study, as I said, the only problem is a radiological BGK. So like this patient, was one of the young patients, around 17 years old, and after resection, she had a radiological BGK, as you can see here, or residual kyphosis, whatever we can do, but still now the patient is not complaining, and no revision surgery was done for her. So we started with AIS, then severe congenital kyphosis, and then wedge VCR for combined congenital adolescent kyphoscoliosis. And also VCR is applied for patients with mucopolysaccharidosis or Morquio syndrome with local kyphosis. And we had two patients who presented with spastic paraparesis like that. They have a deformed vertebra due to the mucopolysaccharidosis, and we applied also posterior vertebral column resection with perfect reconstruction of the alignment and neurological improvement in both patients. Also, vertebral column resection can be applied with patients with rigid post-traumatic kyphosis. We operated 23 patients with rigid post-traumatic kyphosis. For example, this posterior only vertebral column resection reconstruction using mesh cage was perfect result for correction of advanced stage. So during this experience, we have some protective tips to try a trial to minimize the complication of this major surgery. For example, to decrease the neurological complication, we advise that you have to control the blood pressure during the osteotomy. Don't do the osteotomy or the correction with low blood pressure, with mean blood pressure less than 60, because the blood flow to the cord is mandatory, and you avoid severe hypotension and have some thrombosis of the minute vessels and can result in neurological deficit. Also, try to always to stabilize the spine, either by temporary rod during resection. You can put it at the other side and start resection, and then you transfer the rod to the same side and you go to the third and resection. But don't leave the spine very loose during resection, especially if you're using an osteotome or a gauge or whatever the instrument we are using. Also, we have to carefully protect the neural element all the time of the surgery. And actually, one of the protective tips is that we try to preserve the posterior longitudinal ligament a very thin rim of bone attached to it. This allows us to reconstruct the height of the anterior column adequately without buckling, over compression, or stretch of the cord due to over distraction, because we keep a very thin amount of bone with the posterior ligament just anterior to the dura. This helps us to know when the cord is markedly stretched or it is buckled. And usually during correction of deformity, you have to stabilize the spine, either with spreader, with anterior screws, or manual workers holding the shoulders of the patient's legs to avoid translation or collapse of the spine. All of these elements are fine and help to decrease the neurological complication during this big maneuver. Another most serious complication is pseudoarthrosis and implant failure, and all of this require revision surgery. And some tips to decrease this is adequately prepare the end plate. Usually always use a lot of cancellous bone graft. And usually after resection, if you carefully reserve the bone, if you carefully clean the bone from the soft tissue, you will find a very big amount of cancellous bone graft. You have to put bone graft everywhere to ensure rapid healing. And also you have to put a rigid fixation. Rigid fixation at least 3 levels above and 3 levels below. And actually, if you felt during the surgery that the bone quality of the patient is not so good, you don't hesitate to add another levels of fixation or cemented screws or whatever to have a very rigid fixation to protect the spine till healing. Because healing for this big defect take a very long time, around 1 year, 2 years, and so you should have a rigid fixation to protect this healing. And of course, recently with mesh cage reconstruction of the anterior column or expandable cage reconstruction, you should adequately reconstruct the anterior column to prevent bending force and failure of the posterior implants. Another complication is the instance of BGK or proximal junctional kyphosis, and this can be minimized by proper selection of the upper instrumented vertebra. Don't stop your fixation at a junctional zone. Try always to restore the sagittal balance and the pelvic parameters, and avoid injury of the facet capsule or for the non-fused level. All of these steps help to minimize the incidence of BGK, although radiological BGK is a common complication, especially when you are working on a young adolescent patient with still potential for growth. So finally, to take home message, the vertebral column resection is a very powerful correction for complex deformity. However, it is technically demanding with long learning curve, and you should have a perfect preoperative planning is mandatory before doing the surgery in order to achieve a very good result. And thank you all for this attention.
Thank you so much, Dr. Bilal, for your presentation. And I'd like to thank the whole gathering of these distinguished faculties. We have now Dr. Mariam, Dr. Abdullah Shah, Dr. David, and Dr. Walid Hekel are with us. And I'd like to hear from the panelists. We have friends and colleagues. If there is anyone have comment or question to our four speakers. May I start with Dr. Mariam? You know, during our faculty time, we used to know that soft tissue healing cascade takes 3 months, and bone healing and fusion start after 6 months. So is these two figures, 3 months and 6 months, have special or peculiar training sessions or physiotherapy programs regarding patients after the surgery?
Yes, up to 6 to 12 weeks. We called it as a maximum protective phase. So we want to protect and respect the tissue healing. And we do have goals at that stage. We want to normalize the gait pattern for the patient. We want to start to let him do his ADL activities with as much as less pain that he has, and start with the muscle imbalance that he has post-operatively, breathing exercises that we start, but we do not do any aggressive mobilization or aggressive strengthening for the muscle until we make sure that we passed the maximum protection phase. Did I answer your question?
Yes, sure, absolutely. May I ask Dr. Abdullah Shah, regarding cases with Arnold Chiari malformation and scoliosis deformity? In the literature, you may found that when we are dealing with the Arnold Chiari and the compress, you can have a regression of the scoliotic deformity. So this is like what you said regarding syringomyelia as well. Treating syringomyelia or the serines inside the cord, we may have regression of the scoliosis. So in your case, Ceres, do you have the same scenario, or you need to intervene among the neurological axis abnormalities and the deformity in the vertebral column?
Yes, I share that the picture. Let me see again. Yes. Yes, this is the paper from Journal of Pediatric. I just found this paper in the literature. Personally, I don't have such experience because most of the time patients come late in our setup, and they are mostly above 60-degree curve or 50-degree curve, along with mild serings. So we go straight away with the correction of deformity. But literature says that if there is curve is flexible and the patient comes with 30-degree curve or 40-degree and with serings, dealing with the serings leads to regression of this scoliotic curve. But I don't have the my personal experience in that kind of patients.
Okay, great. Is any one of the speakers or one of the panelists or the moderators want to ask our friends, or shall I continue?
I would like
I've got a question.
ask David.
Yes, Dr. Yusri, please.
David, thank you for your two talks. Excellent. And could you tell me, are the screws hydroxyapatite coated?
They are, because they are only available coated. We have not seen any single loose screw. So I believe in the future, it's probably possible to use uncoated screws, because the weak part of this implant is the cord. So the cord will break before the screw gets loose. It's different than a screw rod combination. But at this point, all the approved systems only have coated screws. But in the future, I believe we can use uncoated screws.
And after maturity, would you recommend going and cutting the cords? To,
no, because the cord will break. It will always break. We see that quite a while. We see that quite often, especially in lumbar curves. There's a breakage rate of maybe 80% or so. And I've seen that Baron Lorna tomorrow will also speak. He also has the same numbers. The goal is to have it stable as long as possible, maybe 2 years or so. And when the cord breaks after 2 years, we've seen many patients where the curve does not come back because of soft tissue remodeling. So there's no need to cut it.
Thank you.
David, may I ask you regarding what is the cause of adolescent idiopathic scoliosis? Do you believe? What is the cause?
The cause?
Yes.
You mean not related to VBT?
No, actually, you know, when we are thinking in vertebral body tethering, that we may say that the cause is overgrowth of the convex side in comparison with the concave side. So tethering
Yeah.
the convex
Okay.
side simply will allow growth of the concave side. This is a simple way of
Yeah, so I
thinking
understand.
about the effect of vertebral body tethering. So what is the cause of scoliosis?
Right.
What do you think?
So the reason for VBT, the reason that VBT developed is growth modulation, because the etiology is not really known, but there's an overgrowth of the anterior column and also a wedged vertebra but mainly in the thoracic spine actually. So there's quite a number of studies that show exactly what we believe: anterior overgrowth, wedged vertebral bodies, but 2/3 is in the thoracic spine. If you go to the lumbar curve, like a Lenke 5, more than 2/3 of the curve comes from the disc. So that's why I believe VBT can be done in the lumbar spine a little bit later, because you have to modify the disc. But if you do it in the thoracic spine, you have to reverse the pathology of scoliosis. So you have to reshape the bone so you have to tether the convex side, but also because it's in the anterior column, you will also increase kyphosis when the kid grows, kind of reversing the cause of scoliosis.
Dr. Walid, do you have a comment or?
Yes, yeah, just comment on David for his excellent presentation, and I'll ask Dr. Mariam a question also, if you don't mind. So David, going back to the question of Muhammad, so that this also entailed the position of the cord, because as we know that the principle is which has been first described by the prof in Leeds, about that the principle is that there is overgrowth of the anterior column. And also Michael Ruffin in Germany, most of his cases, he does it two-staged, even in simple flexible curves, because he thinks that that's the only way to restore the sagittal balance, by shortening the anterior column. So do you put your cord, that entails where you put your cord, if you're going thoracic or lumbar, you go a bit more anterior, if you're doing it in the thoracic to apply more compression anterior, and vice versa in the lumbar spine, or it doesn't matter?
Yeah, so I try to position my cord, but we see very complex reciprocal changes. So in the thoracic spine, I try to put my apical screws more posterior and my end screws more central, so that I also derotate by tensioning the cord. For the lumbar spine, I try to be as far posterior as possible, and I also use two cords. But the interesting thing is, we were afraid of kyphosing the lumbar spine, and we will present our data at the SRS this year. The sagittal balance after VBT improves significantly. We have increase of kyphosis, but we don't have loss of lumbar lordosis. We don't have a real explanation for that, but we believe that in the lumbar spine, by centralizing the disc, lordosis increases, and in the thoracic spine, by compression of the disc, because it's more anterior, kyphosis increases. But it's really a complex topic. The good thing is we know that it improves. We don't know why it improves.
But do you measure, because of the lumbar lordosis, you always stop at L4, and the majority of the lordosis comes between L4 and S1. So do you look at the lordosis as L1 to S1 when you measure it, or you look at it segmentally in the upper line lordosis and lower lumbar spine? Because you said that all of the cases, can you hear me?
Yes.
Can you hear me, Dave? Yeah, because all of the cases, you stopped at L4, and the majority of your lordosis is below that. So when you measure the lordosis, you measure it L1 to S1, or you do it different per lumbar lordosis, lower lumbar lordosis?
Yeah, so it actually depends on the curve type. Not all of them stop at L4. We have many at S3, and we also have many that only in the thoracic spine. But planning VBT doesn't really look on sagittal profile. I don't do it in thoracic hyperkyphosis, but for lumbar curves, I don't plan my surgery based on the lordosis, because we have done biomechanical cadaver studies on this, and the spine is still able to flex and extend around the cord, so it doesn't really matter. It's not like a fusion where you have to look at this. You saw it on the video. They are still able to flex and extend nothing happened. Yeah.
No, it's actually, I think this is the future. mean, as you know, in UK, we had not have it still approved by the NICE. It's still an experimental, only done in few centers in London. But I do believe that it has got its role in the future, and most of us, as we move to navigation, most of us will be moving to this technique in the future. So thanks a lot. My question to the experience with the spine core bracing, including that with your physiotherapy program.
I'm sorry, can you say that question again?
You know about the spine core bracing, dynamic bracing?
Bracing, yes, but your voice is cutting.
Spine core brace.
Spine core brace.
Spine core bracing. It's a flexible brace with the straps, which is not like the rigid bracing. The spine core.
Yes, I heard you. I couldn't hear you at the beginning.
Yeah, sorry about that.
Yeah, I heard about it, but
so
I'm not experienced
also?
with. I don't use it, but I saw clinicians that believe in it and use it. And again, literature review is not enough in the effect of different type of braces.
Yeah, but that's right, because I used the spine core brace, and we have done a study with Sheffield about it, and we're using also another study about the nighttime bracing versus the full-time bracing. And from my experience, the spine core brace in patients with truncal shift, it does work very well, and so far it's the only brace I have seen which can do some correction, not just slowing down the curve progression. It does do some correction in the curve, especially in patients with big truncal shifts. So I think it's worth including that possibly with the physiotherapy program.
Yes. Thank you.
Thanks a lot. Thanks.
So thank you so much. And by this, I'd like to conclude this session, and we'll start the next session in 5 minutes, only to stretch our legs and drink something, although we are sitting at homes. Anyway, the next webinar will start in 5 minutes, and it will be some technical webinar, tips and tricks. We will cover only exposures in spine deformity. And I am happy to have Professor Yusri Al-Hawari, Professor Walid Heikel, Professor Sharif Al-Ghamri, and Dr. Yahya Al-Prompoli as a panelist. And if David have a time, Wael Al-Qasim, Muhammad Ramadan, and Abdullah Shah have a time, please join us. It will be a fruitful discussion regarding exposures in spine deformity. So 5 minutes and we'll meet again. Thank you so much.
كويس كده
Abdulaziz. Abdulaziz. Thank you so much for being with us from our beloved country, Egypt. I am happy to continue with you the last webinar for this day. It is covering tips and tricks in spine deformity exposures. I will start by Dr. Sharif Al-Ghamri. He has a presentation regarding spine exposure. Dr. Sharif, can you
Yes,
present?
thank you, Dr. Muhammad. Can you hear me now?
Yes.
Okay, we had divided the surgery into four parts. The first part will be exposure. We will talk about how to reduce bleeding and the facetectomies. And the second part will be screw application. We'll talk about the types and the safety and the usage of hooks and subliminal wires and the screw density. And the third step will be the correction technique and which side to start and do osteotomies. And the last one will be about the closure and doing the decortication and costoplasty. So today we're going to start with the first step, which is exposure. Share video, Aziz.
Sure. Here are some tips and tricks for the scoliosis surgery. We start by planning the surgery and seeing the X-rays, the AP and lateral views and the bending views. And then we decide what levels to be fixed. And we have to make sure that everyone in the room, including the company representative, knew the levels we are going to fix. This is just to make us easier on the operation. And then we plan the line of the surgery on the body of the patient before draping. Then, after draping, we expose the wound on a sequential base. That means if we are going to fix thoracolumbar curve, we start by the lower part of the incision. This is the lumbar curve. And then expose the wound, the lumbar curve, and put the screws. After finishing the screws on the lumbar curve, we extend the wound on the thoracic curve. This is reducing the blood bleeding during the surgery. We start in the midline and of the muscles from the spinous process meticulously and very carefully, so we can strip the muscles as you can see now. Of course, we have asked the anesthesia team to give us a hypotension anesthesia. This will make the field as you look here in the video. It's completely bloodless field. And we continue on stripping the muscles till the spinous process or the rib, which is the liver. So the stripping continues, and we expose the wound, as I said, sequentially. We didn't touch the above levels. We are concerned only with this level, the one we're going to put the screw. And remember, we did not yet know which level are we in. So we only expose the wound, and I'll show you now where we put the screw. Here we say we expose either the transverse process, remember we don't know yet, the transverse process or the rib. So we start meticulously exposing the wounds, and as you see, there's no bleeding. Now we are going to put the screws in this level. First step is to do a facetectomy. That
Actually, we use either the osteotome or the chisel or the tip. And here we remove part of the facet. And we do this for every single level we use to fix, or even not to fix. We're going to pass the screw in this area. We also do a facetectomy in this. There usually is some bleeding after we do the facet, so we just stop it. And then remove part of the pedicle and use the awl to start putting your first screw. After putting your first screw, we check by image intensifier to know which level are we. Okay, Mohammed, you can start questions now if you like.
Okay, thank you, Dr. Sharif. I think that's enough to start our webinar regarding exposure in spine deformity. And I'm happy to have our mentor, Professor Hawari, Dr. Walid Hekel from England, and Dr. Yahya from Boli as the panelists. I will start actually by choosing the table. Dr. Hawari, before positioning of the patient, you ask the assistant to choose a special table. We don't have Jackson table here in Egypt. So what is the recommendation that you inform the assistant that to select the room with which kind of table, radiolucent table, take AP, lateral view? Please, can you give us some tips and tricks regarding selecting the table for the surgery?
I would use a neurosurgical table, which can go down to 50 centimeters from the floor level, and also a translucent, because we need to get an X-ray AP and lateral. And the stand of the table should have like a cantilever effect, where you can push the patient at the top of the table, and nothing in between your image intensifier foot and the patient. So, but if you have a table with a middle pillar, you cannot do that. So you need like a cantilever neurosurgical table. And if you don't have a Jackson table, this will do. We're doing all our surgeon table. And we use like a 4-pillar frame, and the 4-pillar frame is a cheap frame. You can do it. It's nothing special. You have 4 pillars which are covered at the top by gel coverage, which is soft for the patient. But try to position your patient yourself, because if you let some other person do it, you will always regret it. So position the patient yourself, have the abdomen free, nothing pressing on the bony parts, the shoulders is not stretched, and pressure marks avoided. The head is nothing pressing on the cheeks, the tube itself is not pressing on the lips. All these points you have to take care of it.
Okay, Dr. Sharif, you showed us bloodless field actually. So pre-operative, do you prepare blood for the patient?
Oh, yes, sure. Even this medical degree, I mean, yes, of course, you must have some blood. And we ask anesthesia to give us a hypotensive anesthesia. That helps us a lot during the surgery.
Okay. Dr. Walid, do you inject lidocaine and diluted adrenaline before doing the incision?
No, not in any operation. So I use we have the Jackson table.
Dr. Walid, I think the voice is interrupted. Maybe there is internet instability. Can you repeat?
blood transfusion.
Dr. Walid, your voice is interrupted totally, so we cannot hear
First,
anything.
all of the patients are cross-matched between 2 to 4 units, but these are the blood salvage procedures that we.
Dr. Walid, can you repeat what you said? I think we lost Dr. Walid. So, Yusri, do you use some medications to decrease the blood loss while we are exposing the surgical?
Can you hear me now? Can you hear me?
Yes, Dr. Walid.
Sorry. So I'm sorry about that. Yes. So basically, yes. So you do so I use cell savers. I use tranexamic acid. In some of the patients, we try to give them the bloods that they lose intraoperatively in the first 6 hours. But in a few of these patients, they had microscopic hematuria, so we stopped that. So all of the blood in the drain is not re-given in the first 6 hours as used to because of this microscopic hematuria, and it happened only in 3 patients, but they try to play it safe. So yes, so that's in terms of position, and I agree with Professor Yusri about the positioning. This is very important, not just because of the adequacy of the exposure, because sometimes they do the draping. If you leave somebody to do the draping for yourself, they found that they put it either too low proximally or too high distally, and you struggle with that. So you need to give yourself the big access to the spine. And also the positioning of the arms. Many patients, if they don't put it in a 90-90 position with the arm support, they can wake up with some axillary nerve problems. We have seen that. And all of these are not medically defensible, medical legally. So lots of care about patient positioning, the pressure points, use of heel cups for the heels. So this is very important. And the Jackson gives you also this facility because you're having good padding for the iliac crests and the proximal thigh and for the chest. So I think it's the ideal table for this operations if it's available.
Dr. Yusri, some colleagues, before they used to open the whole wound from the upper instrumented vertebrae to the lower instrumented vertebrae and finish the exposure, they use muscle relaxant during the exposure, although there is total intravenous anesthesia due to neuromonitoring, but they use the muscle relaxant because it decreases the blood loss as well. But we know that you used to rely on sequential wound exposure. First, the left side in the lumbar spine, then the right side, then go to the dorsal spine. So do you find difference between both techniques, especially you don't rely on muscle relaxation at the beginning of exposure?
First, we don't use muscle relaxants because we need to take a basic monitor signal before doing any manipulation to the cord, either hammering or facetectomy. So we don't use it. Using any infiltration, no, it's a waste of time. And also it gets the opsite you put in the wound becomes loose, and then the blood will go under the opsite and the field will look mucky. The third thing, yes, sequential wound exposure to me is a good technique. You don't need to expose the whole spine at a time. You're only working at a place, and when you're working at one place, you need the exposure at that. If you're not working at the other place, you don't need to expose, because the muscles get dry and it's exposed to the higher infection. Since we're using this sequential exposure, we have nil infection. We haven't seen infection scoliosis for years. And the other thing, also we are not seeing delayed infection as we used to see before. I believe that delayed infection is a bug which has been introduced during the surgery, and it remains silent all the years, and at one stage it flares up. And that's why we're seeing less delayed infection than we used to see in the past.
Thank you. Dr. Yahya, do you follow the same while managing cases with early onset scoliosis? You are muted. Kindly unmute yourself.
So if you're speaking about early onset scoliosis as a mean of putting a growing rod, so we call it a distal foundation and proximal foundation. So we'll just expose two levels. You will expose them subperiosteally as if you do like a final fusion with your pedicle screws, and then go for the proximal foundation and expose it subperiosteally as well, and then put the pedicle screws. Usually the bleeding is not a huge problem in early onset scoliosis because the incisions are so small and you're working only on 4 levels. So, but still you will follow the same principle. The only difference is that you will tunnel the rod subphysial. Otherwise, the same exposure. Yes.
Do you use neuromonitoring while doing growing rods?
Yes, for sure. So yeah,
it's mandatory.
Yeah. Always neuromonitoring. Yeah, even if it's a small curve, just a distraction on the spine could cause some neurological deficit, and I have seen that, and I have sometimes removed the rod after putting it. So yes, it's mandatory in every case.
Okay, Dr. Sharif, regarding the tranexamic acid, do you use it systemically, that we give the patient at the beginning,
Yes.
bolus dose and maintenance, or you use it locally as well?
No, we don't use it locally. We only use it by the anesthesia. The problem is not always you can find it. Sometimes it's deficient.
Okay, Dr. Walid, can you
Can I say something about the tranexamic acid?
Yes.
Yeah, so for tranexamic acid, there are multiple school of thoughts about it, about the loading dose and the maintenance. So that some people will say that we'll just put the loading dose is 10 milligram per kg, and then maintenance is 1 milligram per kg per hour. And some people will increase that dose to 20. And even there are some studies saying that you can increase the dose up to 100 milligram per kg as loading dose if you are planning an osteotomy. So it's a wide variety of school thoughts about it. I personally use 10 milligram per kg if I'm just doing an AIS. If I am planning a 3-column osteotomy, I will use the maximum dose. And so far, I haven't seen any problems with it. And it really decreases the blood loss. It's a very good thing.
Okay, that's great. Is there any tips and tricks that can be followed during exposure to prevent BGK? Dr.
You're asking me?
First, before going into that, there are several tools which should be present in all deformity kit. A good Kapner, 1.5 or 1.2 Kapner gouge with a sharp, very thin. Also, you need a big or a large nibbler, like a Sam Stilly nibbler. This will save time. You need a sharp cob, always sharpen your cob to be a razor sharp, and try to go subperiosteal, and especially you're dealing with kids, they still have the apophysis. You can split the apophysis and do subperiosteal, and this you get like a bloodless field, like Dr. Sharif Al-Ghamri has shown. As to how to prevent proximal junction kyphosis, first, you don't see it a lot in scoliosis. You see it in adult surgery, but in adolescent surgery, you don't see it, and you don't expose the facet above your fusion, and you can just put your hook or your screw without exposing the facet above the sheet.
Dr. Walid, are you familiar with minimally invasive approaches in spine deformity, in scoliosis surgery?
Yes. Yes. We do MIS. We started that, but we do MIS mainly in tumors and in trauma. But also we started because we started using the navigation, so that can allow you also to do that. But going back to the PGK, I agree with Professor Yusri that it's a major problem if you are overcorrecting in Sherman's kyphosis and in kyphotic deformities. As also mentioned earlier by Dr. Joseph, that I do the same principle, is that when you put your rod, try not to bring your upper rod, the upper instrumented vertebra, by pushing your rod down. Make sure that your rod is resting by over contouring the rod proximally, resting on the upper instrumented vertebra. But if you feel that you have to pull your upper instrumented vertebra, okay, as we're talking this about the exposure, it starts from the beginning that once you go to the top, I preserve the intraspinous ligament and supraspinous ligament. So when you go to the proximal end, I do it and I ask my fellow registrar to start to make his exposure away from the midline so as to preserve, even if sometimes it's flimsy and not so strong, but I still try to preserve it, not to take the capsule at all proximally. Of course, using the burr at the top end when you're finding your entry point for the upper instrumented vertebra, and the other techniques that we know about, the over contouring of the rod, and because I personally use the transitional rail rod, so I think this is doing this transition of forces between the very rigid part to the soft part, so adding some soft landing at the top. So we do not see much of that. And I think the PGK is more a iatrogenic problem rather than in idiopathic scoliosis and in Sherman's or kyphosis. It's idiopathic. The problem we face it is in the adult degenerative scoliosis, that because the patient has got this tendency of leaning forward, and even if you do all of these tricks and you get all of your measurement with the no mismatch between the lumbar lordosis and the pelvic incidence, doing all of the tricks whatsoever, you still see it. So if we're talking about pediatric only, it's not a big problem. We see it more in adult degenerative scoliosis.
Dr. Yahya, would you like to add something? Unmute yourself, please.
As Dr. Walid said, it's very important that at the top instrumented vertebra to go away from the midline, even like one level before that, so that you can preserve the interspinous supraspinous ligament. That's a very important trick. And using hooks, if you are stopping at T2, is quite preferable because you don't need to expose quite as much for putting the hooks, and to allow the slight mobility between the semi-rigid hooks and the non-rigid cervical spine. So I think that is what I can add only.
Great. May I add something more? Is that some colleagues try to do the proximal screws or minimally invasive percutaneous. Some friends as well may try to leave 1 or 2 threads outside the pedicle in the proximal instrumented vertebra to avoid irritation of the facets. So I think all these are tips and tricks to decrease the incidence of BGK while approaching our deformity cases. So by this,
can I just comment on this, Muhammad?
Yes.
Muhammad, I just need to comment on this, please, if you don't mind. Not sinking the top screw is very important in the lumbar curves because of the orientation of the facets is different. I don't think it's very important in the thoracic curve, in the thoracic vertebrae, in the upper instrumented vertebra. So personally, I found that I personally preserve the capsule if I'm doing L4 to S1, for instance. I don't take the capsule at L4 at L3-4. I preserve the capsule and just very minimal nick at the site of the entry point And the problem that if you are sinking your rods, and because the system I'm using is crimping mechanism over the head of the screw, so if you are sinking your top screw, then you damage the joint that you try to preserve. But you don't see this as a problem in the thoracic spine. You do not need to leave it so proud to do that. You see it more because of the orientation. The facet capsule is completely different in the thoracic than in the lumbar. So I don't think it's right, because I get worried to leave the top screw, which is usually a bit proud, because then you can have a chance of pulling out of the screw.
As you said during your the scenario which we are anticipated, you need to put the rod down and contour it in order to engage the tulip without any muscle forces. So
bring the rod to the screw, not vice versa.
Yes. This paper is published by some Turkish colleagues, and they highlighted what I just said. And their conclusions that it decreases the incidence of BGK by decreasing hitting the capsule and decreasing the forces while applying the rod to the tulip. Anyway, it is something can be considered during our dissection. Anyway, by this we can conclude this session, and inshallah tomorrow we'll start at 6, and tomorrow inshallah we will have another session after the webinar covering the screws, types of screws, how to apply screws, different methods for applying screws either in early onset scoliosis cases and adolescent idiopathic scoliosis cases. So thank you so much for being part of our event, and see you tomorrow inshallah. Thank you so much.
Thank you everybody.
Thank you, everybody. Great having you.
Thanks a lot.
السلام عليكم.
شكرا جزيلا.
Thank you.
تصبحوا على خير.